So ketogenic diet. Sorry guys, I'm just trying to do this on a laptop. Okay, so wanted to talk today about the role of ketogenic diet in epilepsy treatment. I'm going to review sort of general concepts of it, the way it's used in pediatrics specifically, and touch a little bit on how it's used in the adult population. The lights just went off. Bear with me 1 second. I have no disclosures, and our objectives are to review the basics of ketogenic diet for epilepsy in children, review the conditions in which it's considered, the management and monitoring of ketogenic diet, both in the inpatient and the outpatient setting, and just touch briefly on some alternative therapies that are related to ketogenic diet therapy. So what is it? So ketogenic diet and its variations are diets that are comprised of combinations of higher fat, moderate protein, and low carbohydrates. And these are still calorically appropriate and adjusted, but very precise diets. What this does is changes how our brain uses energy. And when we do that, it actually has an anti-seizure, anti-epileptic effect. So the brain and the body use carbohydrates which turn into glucose as fuel. And that's our usual way that we run our brains and run our bodies. When we eat a higher fat diet and lower carbohydrates, that shifts to formation of something called ketone bodies. These are formed in the liver and then used in the brain very readily. And that has the anti-epileptic effect ultimately, depending on the level of ketones. Other mechanisms of how this works are less well understood, but we do think that there are multiple mechanisms that are beneficial for the ketone bodies within the brain. This was actually shown for centuries, sort of observed by even doctors as old as Hippocrates, to decrease seizures in patients with epilepsy. And people with epilepsy who would starve themselves, their seizures would decrease. Starting in the 1920s, this became studied as a specific treatment for epilepsy. And as I've said, there are various forms of this diet, varying levels of intensity, I guess is how I would put it, which are considered depending on the patient and the health indications, which we'll get into. So what I tell patients when we start this is that your food is going to be your medicine. So ketogenic diet is complementary to anti-seizure medications, and sometimes we can actually come off medications entirely in certain conditions. What this requires are very precise amounts and calculations of your food, just like you would calculate and take precise doses of your medications, as well as counting macros. Again, the fats, carbohydrates, and protein in very specific ways. And when we do this, we're thinking about the ratio of the total amount of food in fats to carbohydrates. So when we talk about keto, we talk about a 2-to-1 ratio of fats to carbs, or a 4-to-1 ratio in classical ketogenic diet. And that is how we dose the diet, essentially. This requires a physician, a neurologist, and a special dietitian oversight and close monitoring. So the dietitian's role is to provide very precise nutrient mix in recipes specifically for patients, or what we call menus, or in children who are formula fed, the specific volumes of formula mixed with supplements and medications. So as I've said, this needs to be precisely followed in order to achieve lasting seizure control. So it's considered in drug-resistant epilepsy, and what that usually means is that we've tried 2 medications and have not achieved the seizure control that we feel we can. It's usually as an additional or alternative therapy to the medications, and often used in patients who are not candidates for epilepsy surgery, as well as a number of genetic conditions that we refer to as epileptic encephalopathies. And again, this just means that you've gone through multiple medication trials. This is a bit harder. The classical ketogenic diet is not typically offered first line for adult patients with epilepsy, although it is increasingly. So often what we use or recommend for adult patients is something called the modified Atkins diet. And this became, I think, popular in the 70s. and now is something that's used more in a health context for weight loss and diabetes, but also for ketogenic diet therapies. We'll get into sort of what that means in a little bit, but that is something that's a little easier to sustain just because the carbohydrate ratio is not as low. And for those people that have been eating a regular diet most of their lives and enjoy carbohydrates, it can be a little bit easier to execute. So these are the conditions in which keto diet therapy is considered, and a lot of these are childhood conditions. So Dravet syndrome, Doza syndrome, or myoclonic astatic epilepsy, tuberous sclerosis complex, GLUT1. You may be familiar with Lennox-Gastaut. Some infantile epilepsies where children are fed with gastrostomy tubes and are formula fed exclusively. That's actually a very straightforward way and very effective way to utilize the diet. There's evidence that this helps with infantile spasms as a second or third line treatment. And it can replace some of our standard anti-epileptics, which are less effective in that condition. It can be started emergently for status epilepticus in the intensive care unit. Certain metabolic conditions, it's very helpful. And then in some cases, we do actually go to ketogenic diet for children who may be more neurotypical, but have generalized epilepsy, such as absence epilepsy or myoclonic epilepsy, where multiple medications have been tried. And again, sometimes those patients can use what we call a modified keto diet with a lesser ratio of fats to carbs, which is easier to execute and sort of implement into your life. How effective is it? Well, about 50% of patients on the classical ketogenic diet, which is that high fat ratio diet, have a 50% reduction in seizures, which can be really significant. And 10 to 20% of patients may have up to a 90% reduction. This can mean that you may be able to be on one or no anti-seizure medicines, and that can really improve the interplay of some of the complications of side effects, cognitive side effects, physical side effects of anti-seizure medicines. There was a meta-analysis done that basically sort of putting this all together, where this range of seizure reduction was found in about 60% of patients overall, regardless of the cause of their drug-resistant epilepsy. It's been found to be more effective in seizures that are not focal. So again, these more generalized seizure conditions or genetic seizure conditions. And about 30% of patients have complete resolution of their seizures when they're on diet therapies. Oh my goodness. So how is it managed? We start out with a very extensive consult between a neurologist and a dietitian. There's a lot of laboratory work and screening lab work that's involved. We begin by taking any carbohydrate containing medications that you're on, even things like over-the-counter meds or other meds that are not seizure related, and making them into, or finding a carbohydrate free or carbohydrate minimal formulation. So for some children in particular, that means using tablets, crushing them, and diluting them in water. And it makes it more important when you're thinking about things like Tylenol and Motrin to have alternatives to some of those liquid medications that are available. It's also important to look at the context of what's going on in the family in terms of course, in pediatric neurology and really all conditions, we're thinking about the context of the patient and the family as a whole. And with some families, we need to think about, is this feasible? Do they have other children that are going to be affected by having a sibling with special foods? Are there allergies to take into account? Are there other conditions? Do they have access to ketogenic friendly foods, which can sometimes be more expensive because they are, higher fat? There's more meat and proteins to be purchased. So these are all things that we really have to think about and talk through with families before we say, let's go for it. When we do the classical ketogenic diet, for the most part, the child is admitted to the hospital for several days. This allows us to do intensive monitoring of the child and also educate the family on some of the logistical things that they'll be doing at home. So there's a lot of one-to-one education with the dietitian. Menus are formulated for the family. They're initially started in the hospital and then they take them home. They learn how to weigh their their foods with a gram scale, because it really is that specific and that precise. And we monitor blood sugar carefully, because when you initiate the diet, you can sometimes have hypoglycemia. Also, we teach families how to do ketone monitoring. So ketones are spilled into the urine. That's kind of how we know you're in ketosis. And we look at the level of the ketones. We can also do this now with point of care blood ketone monitoring. So a lot of this is changing and becoming a bit easier, but there's a lot of ways to monitor at home. I mentioned KetoCal here because that is the formula that we use for babies and toddlers that are taking exclusively formula-based feeds. That's kind of the gold standard, and that allows us to be very precise with volumes, which sometimes is easier for families that they're not having to weigh food. And again, this is like medicine, so it's increased in ratio over a few days. Sometimes when you're admitted to the hospital, we actually fast the patient overnight to prepare them and get them into ketosis quickly. So there's a lot that takes place in those 3 to 4 days in the hospital typically. We do sometimes do home initiations. What I mean by that is we kind of guide you through it as outpatients, starting slowly at home and doing a slower titration of either the formula or the foods. And that's also something that's more readily done when you're on a lesser ratio diet. So again, the families, what they're really responsible for is following these recipes carefully and also making sure that supplements are given, because we make sure that children don't become vitamin deficient on this regimen. Obviously, we want to make sure there's an open line of communication with the neurologist and the dietitian regarding any concerns, any moment-to-moment tweaks to the diet we need to make, and also if there needs to be additional sort of more intensive monitoring of things like blood sugar. At home, parents will be checking urine or blood ketones, and we follow you very closely in the epilepsy clinic and frequently get labs. Usually those are every 3 months. We're monitoring the patient's growth and their electrolytes. There are sometimes some shifts in the electrolyte balance on this medication, or rather the diet. Once you're stable on the diet, that's less important because we're not making a lot of tweaks, but the initial phase of the diet can be a bit intense. There are some side effects that are important to recognize with the ketogenic diet. A big one is GI symptoms. So there can be anything from diarrhea to constipation. Because you're taking in this high fat food, a lot of times we do see a worsening of gastroesophageal reflux or vomiting. We manage that with medications, and with some of the GI symptoms, with the diarrhea and constipation, adjusting some of the fat content, adjusting the amount of things like oils that we have in the diet. It can be helpful. So it's a very individualized process. We do see increased lipid values in the blood. Interestingly, long-term studies have showed that this diet ultimately, even though there's elevated overall lipids, we don't see a real worsening of the sort of dangerous lipids like total cholesterol or triglycerides over time. And some of the studies have shown that there's actually no long-term cardiac effect, as you might think with like cardiac disease related to high fats in adults. This doesn't necessarily tend to happen in children. And this is something that's being studied in adults currently, but it's not well understood whether there is an additional cardiac risk being on a higher fat diet. We do see either growth failure or deceleration in children. And on this diet, children do tend to have sort of smaller stature. So that is something to be mindful of. Bone disease and calcium deficiency can develop. And so we're very careful about supplementing with calcium and vitamin D in particular. And kidney stones can develop because as you develop the ketone bodies, you're actually having a little bit more acid in your blood. And so that can develop what's called a metabolic acidosis. And overall, and long term, that can lead to kidney stones. So there's medication that we give for that to protect you against that. We monitor it very carefully. And it's something that we are mindful of long term. We kind of can treat the ketogenic diet much like we do anti-seizure medicines if it's successful. So, the rule of thumb you may have heard is that if you've been on anti-seizure medicines for a couple of years and you've been seizure-free, in some conditions, you can consider coming off medication. Certainly that's different depending on the condition that we're dealing with, but that's true also of the ketogenic diet. We do want families to trial the treatment for at least 3 months to show an effect of the diet before we consider it to be ineffective in some cases. It really can take that long to demonstrate a trend of seizure control. And so, again, this is a commitment, and it's definitely a bit of an intense process in the beginning, but we ask families to really commit to this for at least 3 months. We need to wean it off for the most part if we do decide to stop it, whether for a period of seizure freedom or whether it's intolerance. And so that becomes a slow adjustment of your macros and your volumes of food over time, increasing your carbohydrate content again. There are conditions where we can stop it rapidly, particularly if seizures are worsening in an ICU setting. The other thing I do want to mention, which I didn't write down here, is that when children are ill, sometimes that can make maintaining ketosis very challenging. So when children are admitted to the hospital for their, run-of-the-mill things like viruses or other complications, and they have epilepsy and on ketogenic diet, we have to ensure that there's a clear plan in place to maintain the diet. And that often requires making sure that the team are very aware of things like fluids and medications that they're getting. And one of the things that we have and are developing here at Maine Health is what we call a keto passport. So empowering families to have that information on hand, where if they go into an ER or a hospital where they're less familiar with the ketogenic diet, they're able to give a program to the providers and say, hey, this is what needs to happen. My child or my family member is on this diet. So I just want to briefly touch base about the other dietary therapies for epilepsy. These are sort of different versions of ketogenic diet therapy. So again, I already spoke about the modified Atkins diet, and this is the one that often adult patients will start. This is a diet that is low carb. It's usually about 20 grams of carbohydrate a day. And if you're walking around counting carbs yourself, if you've ever tried to lose weight, the average American diet is something on the order of 150 to 200 grams of carbs for a lot of people. So maintaining a diet even under 80 carbs can be really challenging, grams of carbs. So this is a significant change to life, but it's definitely something that's doable. And you've probably come across it, like I mentioned, in sort of weight loss programs. So this is definitely been shown to be effective. And it's something that over time, it's been shown that it's better with compliance because it's an easier diet to execute for many people. There's also a modified ketogenic diet, a much lower ratio. So like I said, with classical ketogenic diet, we have anywhere from a 4-to-1 ratio of fats to carbohydrates down to a 2-to-1 or even a 1.5-to-1, depending on the tolerance of the diet and what we've achieved with seizure control. This is just a 1-to-1 kind of bump up of the fats to carbs, and this can also be effective and actually is something that we transition kids onto long term when they've done well for a while. A low glycemic index diet is similar, slightly more carbs than a modified Atkins. And that's something that we can use in some childhood epilepsies that, again, is less restricted. The efficacy is not as clear for that, but I do have some patients try that out of the gate if they're thinking about ketogenic diet and their child is like a toddler that's going to school and is encountering snacks in school and being around their peers, trying to tweak a little bit and at least count carbs and maybe make some healthy substitutions, which will lower the carb content of their diet in a low glycemic index way, can actually be a good introduction. So just want to provide some of our major resources on ketogenic diet. Of course, you're here through the Epilepsy Foundation, and there's some really great, very succinct information on the Epilepsy Foundation website about ketogenic diet and some basic questions. One of the really wonderful resources we have for ketogenic diet therapy for both us as providers, but also for patients and families is the Charlie Foundation. And so it's charliefoundation.org. It's available to everyone, and you can check it out and read about it. Also, Cure Epilepsy has some similar resources. So these are both really great references to kind of read a little bit deeply into sort of the mechanisms of ketogenic diet in a really digestible way, and also think about it specific to conditions that you may be familiar with. All right. So I probably burned through that pretty quick. I'm going to stop my share. And hi, Liz. And I see that there's a bunch of things in the chat. So I'm going to run through and see if I can answer your questions. Okay, so Joey Gallin, if I'm saying your name right, asks, is the only reason that a modified Atkins diet recommended versus a ketogenic diet in adults is due to likelihood of adherence, or is there not additional benefit for a strict ketogenic diet? There actually is very good evidence for classical ketogenic diet. Oh my gosh, the lights went off again. In adult patients, it really is about adherence for many people. And so if patients are sort of motivated or able to be compliant with classical keto or one of the modified ketos as opposed to modified Atkins, it's something that's quite effective for their seizures. Yeah, the Nutritia calculator is awesome, Christine. I'm glad you put that up there. And it says, she said, they will help work with you and your family about the cost and working with the school to get a part of the nutrition of the lunch program. Yeah. It's great. And there's also a lot of resources through Nutritia for families that may not be able to obtain things like gram scales and the equipment that you need to do your diet at home. So a lot of resources available through the company that produces KetoCal.
And we'll also help with that too, Dr. McDonough. So
Great.
if you have families that are needing help with the cost of any of those products, our organization is happy to help families with purchasing, the scales or whatever they need. Those are some of the things that we are happy to help the families with.
That's excellent. I'm sure we're going to be in touch a lot more about that. I'm new to Maine, and so I'm still getting used to what's available. But I also learned recently that Maine WIC covers KetoCal, which is awesome. So that's something that we're going to be using a lot for our families. I got muted?
Yes, I think I hit it by mistake. I am so sorry.
That's okay. I just was hoping I wasn't muted the whole time.
No, you were fine. I just wanted to say thank you so much for joining us and having you be a part of our conference today, Dr. McDonough. We're so lucky to have you, and Maine is very, very fortunate to have you be a part now of the epilepsy program. This is
Thank
going to
you.
give such a huge piece to our families where before they would have to travel out of state to even try keto. And we know that the cost of just traveling now is so huge that being able to offer this program to Maine is just wonderful. So, and New Hampshire families that do come to Maine Medical Neurology as well. So thank you so much, Dr. McDonough, for joining us today.
Sure.
There is
make a
no,
quick
go ahead.
plug. Do we have a minute? I know
Yes,
I
please
joined
do.
late. So our program, I should have just put a slide up here for the update. So, I work with a dietitian through the complex care program here in pediatrics. She's wonderful. Her name is Kelly Falone, and maybe we'll get her to speak with us at some point because she's fabulous. She and I are starting to see patients, and we welcome any families that are interested to come see us if we don't have you established as part of our practice. We're sort of thinking about how to get things sort of increasing in terms of our patient volume, and we really want to provide the service locally. The other thing that we are able to do for some families, if you If your child is has consulted at Boston Children's and is already on keto or some um, modified diet, we are able to be a local resource for you. I have had some families sort of transition some of that care to me. I'm in contact with that team. I know the folks well, and we have a Zoom that we do together when we share patients. So there can be continuity and communication locally for you. So I just wanted to let you know that it is definitely a growing program, and we're really excited to be doing it and look forward to seeing you. Thanks so much for having me. And thanks for tolerating these crazy logistics in the hospital.
No, thank you so much, Dr. McDonough. We do have one question. Um, it says, we have working with an adult patient with drug-resistant generalized epilepsy who receives care at a hospital in Boston that does not have a diet program connected to their epilepsy program. What does the process for someone like this look like to be connected to a diet program for someone like that?
We have not had adults yet, but it's something that we could definitely try to fit in. Kelly, our dietitian, has done adult nutrition before. She's actually a very experienced adult dietitian before she joined us. And a ketogenic diet is something, whether you're a pediatric neurologist or an adult neurologist, it's the management is quite similar. So I'm happy to chat offline about your patient and see if we could provide them some local service. Be happy to do that.
Wonderful. And we have one more question. Does the keto diet change the EEG?
It can. Yes, it can improve it because it's just like an anti-seizure medicine.
Um, we had tried that with our daughter and it actually improved her speech. She was completely nonverbal for about 5 years. And when she was put on keto, um, her speech and language just exploded. So there's a lot of other benefits we have seen with keto that is outside just seizure control, but also that as well of just knowing that once you get maybe with some seizure control with keto, the brain was able to kind of make some more connections and be able to expand on her vocab. So that was our positive piece on it when she was on it. So yes, there are so many great benefits of that, and we are happy to provide more information about that too at our organization. So please reach out and we're happy to do that. Thank you so much, Dr. McDonough.
Yeah,
It was lovely meeting you
good to meet
finally.
you. Yeah. And good
And
to see
having you,
your faces.
I know, and so happy to have you. And so great. So thank you, everybody. And thank you, Dr. McDonough. We appreciate
Okay,
you.
take care. Have a great session. Bye.
Thank you. We have our next speaker coming up in about 5 minutes. So I'll speak a little bit about her and exactly what her role is with Maine Health and her background as well. Just going to make sure that we do have her. I did speak to Dr. Taplinger. She will be on and she knows she's coming on. So she is going to be on in about 5 minutes. But in the meantime, I can go ahead and kind of explain a little bit more about her background and who she is. So Dr. Taplinger has been with Maine Medical Center since 2020. She is also part of the practice of the psychiatry tree there. She works in the field of psychiatry, and she's very happy and fortunate to learn about people's experiences and help them work towards their goals. In the spare time, she says, I enjoy exploring the Maine outdoors with family as well. She also did her residency at Maine Health Medical Center in psychiatry in 2020. And she went to medical school right here in Maine at University of New England. So that's exciting, in osteopathic medicine. And she received her DO, her doctorate of osteopathic medicine in 2016. So we're very happy and excited to have her here. She does know that she is coming on. So we do have a few more minutes until she does come on. We have her scheduled at 11:05 a.m. So if you have a few minutes that you want to get up, grab something to eat, grab some water, go to the bathroom, any of those things, please do it now. I also want to let you know that I will be, all of this is recorded today. So again, we will be sharing this presentation with all of you. And then any of the slides that our speakers have had, we'll be happy to hopefully be able to share some of those with you. I know I have Dr. Septelli's, and happy to share those with you as well so that you guys have that information at your hands. But happy to answer any other questions in the chat during that time as we wait. So thank you so much. And we will wait. We have a few more minutes. So welcome everybody back. And we do have Dr. Taplinger back here with us now. So we're so excited to have her. And Dr. Taplinger is going to be speaking today with us about PNES, or psychogenic non-epileptic seizures, or sometimes we call it functional seizures. But I'm happy to have her here today, which is going to be discussing the treatment and patient care with PNES. So thank you so much, Dr. Taplinger, for being here with us today. I am going to make you co-host, so that way you can then share your slides and share everything that you need. So I am going to turn it over to you. So thank you so much for spending your time with us and volunteering your time to be here. I know it's a beautiful day on a Saturday, so thank you so much for being with us.
Thank you for having me. So I'll go ahead and I'll get my screen shared. Great. So thank you for the introduction. So my name is Caitlin Taplinger. I'm a psychiatrist in Maine. I work at Maine Health at Maine Medical Center in Portland, and there I work on the consult liaison psychiatry service. So what that means is that I don't work outpatient, but I do work in the hospital and I see people medically or surgically admitted. And in that context, that's where I've gotten a lot of my familiarity with psychogenic non-epileptic seizures, that in my training beforehand. So I'm very pleased to be here today and talking about psychogenic non-epileptic seizures. And of course, like I don't have any relevant financial disclosures or anything else to disclose at this time. So moving ahead, so we'll start first with just making sure that we're all thinking of things and using the same terminology, because I don't know if it's anyone else's experience, but it's mine that we use a lot of different terms for the same thing in the medical community. And that can be a really challenging place to start, because if you see a PCP who uses one term, you see a neurologist who uses another term, and a psychiatrist who uses a third term, sometimes that can be challenging. And so first, so the term psychogenic non-epileptic seizures. So in psychiatry, things have had different names in terms of diagnoses over the different decades. This is a term we currently use, but there's also a couple other used. One is conversion disorder, with a specific subtype of with attacks or seizures. Another term used in the DSM is functional neurological symptom disorder with attacks or seizures. There's other terms used historically, used decades ago. Like the term pseudo seizure originated, but we don't use that term anymore. And if anything, that we think about stigma and about calling something pseudo. And so that really wasn't, felt to be appropriate. And as such, the terminology has been changed. Apart from the diagnostic terminology, it's also good to think about what do you call the seizures or the events? It's been my experience clinically and in the literature that the events are called different things. And when I'm the provider, or if I'm consulting, I encourage just providers and people or families to talk to figure out the common language and what's preferred. Some people say seizures, some people say attacks, events, spells. And at the end of the day, I'd encourage, just advocacy and finding out the individual prefers them to be called, just to make sure appointments can really be streamlined. And we'll move on. So thinking about the diagnostic criteria. Um, so the diagnostic manual that I use in psychiatry is the DSM-5. And so looking more broadly at the diagnosis of conversion disorder, so not just the psychogenic non-epileptic seizure subtype, what it is a motor or sensory abnormality that's present, for instance, a seizure-like event or a seizure event, with clinical findings being inconsistent from what one would expect with another neurological or medical process, leading to impairment, distress, or evaluation. And so more practically speaking, it's good to think, so what are they getting at in the diagnosis when they mean isn't due to another neurologic or medical process? And so what we think about is neurological. So we would be thinking this isn't epilepsy and that we should be seeing something clinically that's inconsistent from epilepsy. Another one to think about is what about like a physiologic seizure that isn't epilepsy, but is a seizure? For instance, like if someone was withdrawing from alcohol and had a seizure, or if someone had another medical illness that made it more likely for them to have a seizure, but they weren't meeting criteria for epilepsy. And then the other thing to think about medically is what medical things can look like seizures. For instance, if someone syncopizes or passes out and has movements that could look like epilepsy or look like a seizure but isn't, that would also be in the what we call the differential diagnosis, or the things that your providers would be thinking about clinically that could be contributing. And lastly, if we're seeing things that are inconsistent from those clinically on exam, in testing, in the history, that's when we'd be thinking about that it would be this conversion disorder subtype called a psychogenic non-epileptic seizure. And the reference that I'm pulling for the diagnosis is from the DSM-5, which I have listed there. So moving ahead, a common question that comes up is that, are there other types of conversion disorder apart from just psychogenic non-epileptic seizures? And this isn't the topic for today, but I did want to briefly just mention that there absolutely are. And there's actually many. You can see conversion disorder presenting instead of a seizure with weakness or paralysis, with abnormal movements, so like increased movements or types of tremors. You can have it with sensory loss, so with light touch having decreased sensation. You can see other sensory systems affected. You can see changes to vision, to hearing, to olfaction, or the way we smell. There can be changes to speech, swallowing, or some combination of all of these. And I bring it up because, of course, we're here to talk about the seizure subtype, but there are other types out there that other people can experience. And in one's medical journey, when that can be like that feeling of isolation or aloneness, just acknowledging that this is conversion disorder is something that is common, that we do see clinically, and people can be affected in different ways depending on their own situation. So for next, thinking more about what causes psychogenic non-epileptic seizures, I'll start with saying that we don't completely understand it, but it is thought to be psychologic in origin. And looking about so what does that mean, right? So thinking about, if someone has underlying depression, anxiety, trauma, other psychologic processes that can be contributing to these. There's, commonly in the literature and in appointments, it can be talked about that there are a lot of theories about trauma and how trauma can, especially trauma that hasn't been fully processed, it can present physically. When we talk here about like unconscious conflict and conversion disorder, so what I'm meaning there, so conversion is a term that was coined like some decades ago, like considerably further back in time from the DSM-5, actually back in the time of Sigmund Freud, one of the most famous people in the history of psychiatry. And so what was getting at was that it's you're taking an unconscious conflict, something that hasn't been fully processed and that we're not even always aware of, and it can present physically. And that's one of the theories behind this. There's other psychologic theories as well, but that's one of the major ones. And when we think about that, I think sometimes I'm met with, initial skepticism from people. But when we think about the ways that stress or our past can stay with us, it can come out in other ways. And I think when we think about children who might be experiencing stress or anxiety and they have abdominal symptoms, a lot of people don't doubt that, and just in everyday life. And so I often question, so why is this so different? I think it's really understandable that stress can come out in ways that we don't mean it to or have an awareness of. And when I said earlier that it's not completely understood, there's a big area of research in the modern area focused on looking at functional brain imaging and looking at, what differences do we see on brain imaging in psychogenic non-epileptic seizures. We don't see any findings on EEG in psychogenic non-epileptic seizures, but we are thinking about, are there other biologic factors that we can study to help us better explain what's going on and to better guide treatment. A common question that can come up is, can people have both epilepsy and psychogenic non-epileptic seizures? And the answer, not so surprisingly, is yes. And among people with epilepsy, psychogenic non-epileptic seizures is estimated in one study that I have the reference for here and at the end, that PNS is comorbid in 12%. And in people with PNES first, then epilepsy is comorbid in 22%. So it's really quite a considerable comorbidity. And to me as a clinician, it speaks to the importance of really communicating with one's neurologist, PCP, psychiatric provider, just because you want to be mindful about how to differentiate them, because as we'll talk about in just a minute, the treatment for them is very different. And we want you to be, we want people to be the most educated they can and to be the best advocates for themselves and their family members that they can, to really guide the best treatment to have that improvement in that functioning in life. So next we'll talk how are psychogenic non-epileptic seizures diagnosed. And that's, through clinical examination and history, including the evaluation of seizure characteristics, thinking about their appearance, their time course, how frequent are they, and other patterns that your neurologist can comment on. The ideal situation, and really the gold standard is a video EEG where you see one of the seizure events and you're able to analyze the EEG. And as a psychiatrist, I am not going to get into the specifics of that because that would be far beyond my scope personally. But that's something that your neurologist could comment on and explain more. But they're looking for incompatibility because, through clinical examination alone without an EEG, it is very complicated. And so that, the neurologists are really the experts there. And then the next question is, so what do you do after the diagnosis of psychogenic non-epileptic seizures? And what I would recommend is just really talking to your neurologist about the diagnosis and ask questions and then ask some more questions and ask about next steps. And I think when people do research about psychogenic non-epileptic seizures, they look at prognostic factors or factors that can be correlated with the likelihood of someone having like more or less improvement in their seizures. And one of the things that we see in the literature is that people who are more accepting of the diagnosis, they generally do better. And that makes me feel like I can't stress enough the importance of, if you're getting a diagnosis and it's new, of course, that's going to take time for it to sink in. And especially if I imagine if I was in the position of having a diagnosis of epilepsy for years before a diagnosis of psychogenic non-epileptic seizures is made, and if that's the new diagnosis and epilepsy is no longer felt to be clinically present, that's a really big shift to think about. I think thinking about the effect of epilepsy on one's personal life, on the family or support structure and all the changes, and then suddenly to have a different diagnosis, that is a big shift. And, I can't stress enough that, to ask questions, to read, to go to follow-up visits with more questions, just to help you really understand it and understand why the treatment is different. Because at the end of the day, everyone wants, people to succeed in their treatment. And, to me, all the more questions are the better. Looking at treatment options, questions that I'll commonly be asked. So is there a role for anti-seizure medication for psychogenic non-epileptic seizures? And, this is a question, and with all of these, my recommendation is I can't comment on anyone's specific treatment, but I can speak in generalities. And this would be an excellent question for your treating provider. In the literature, so if there generally isn't a role for anti-seizure medication if someone only has psychogenic non-epileptic seizures and the diagnosis is confirmed and there's no epilepsy, but that also doesn't mean to just discontinue your medication. It means, to really talk to your neurologist about it. Because any medication changes should always be guided by the clinician. Is there a role for psychiatric medication? Generally speaking, in the literature, the answer is no. There are some mixed reports in the literature about a couple of sertraline, which is an SSRI, also called Zoloft, and the venlafaxine. But the data there in the literature is really quite mixed. And so generally speaking, the answer to this is no. However, there's the caveats of, and we'll talk about this in just a minute, but there can be psychiatric conditions that are often comorbid or often seen in people who also have psychogenic non-epileptic seizures. So even if it might not be used for this, it might be used for something else. And again, I would recommend talking to anyone's individual clinicians if that's a question. The next topic I have is there a role for therapy? And yes, there is. And again, it's individual specific. And I'll talk on the next slide about a couple of different types of therapy just to encourage general awareness about what those might be. And then the fourth question comes up quite a bit. So what if someone is already receiving therapy, like talk therapy, and then is diagnosed with psychogenic non-epileptic seizures? And this one's complicated, and I really encourage, self-advocacy and talking to providers about it, because there's so many factors that go into this. For instance, when did the psychogenic non-epileptic seizures begin? And was someone already in therapy at that time? Or has someone only recently started therapy? Because there's some types of therapy that are more evidence-based than others. And additionally, if someone's been in therapy for a year, but hasn't seen a difference in their psychogenic non-epileptic seizures, then, I would just reflect, should that be giving people pause and the providers pause and questioning, should something be adjusted? And again, I'm not saying to stop therapy, but should treatment be tailored? Because therapy can be for depression, anxiety, OCD, a lot of different psychiatric conditions. And just because therapy is working really well for one condition doesn't mean that same type of therapy is going to work well for psychogenic non-epileptic seizures. And it's incredibly person specific. So getting into, what are some of these treatments that I'm referring to with therapy? And so the mainstay of therapy that we've researched over the years for psychogenic non-epileptic seizures is cognitive behavioral therapy. And I bolded it just where it's the one with the deepest base in the literature. And, I guess before I even start talking about CBT, I should say that there's a lot of different therapies out there. A lot of times, one that you might hear from people is like supportive therapy, which isn't so much researched in psychogenic non-epileptic seizures. And that's really like support, kind of what it sounds like, supportive visits, therapy, meeting people where they're at and talking through things and being a support. Cognitive behavioral therapy is different. It's very homework focused, which some people like less. And what that is so for cognitive behavioral therapy, the idea is how we think affects how we feel. And both of those can also affect our behavior or our actions in everyday life. And there's this triangular relationship that really emerges between how we think, how we feel, and how we act. And in cognitive behavioral therapy, you analyze that in real life situations that people are going through. And you work on things such as what we call like cognitive distortions or negative patterns of thinking, to really address someone's mental health. Examples, sometimes it's easier to understand things in examples. And so if, you could think about like if someone makes a mistake at work, that could trigger an automatic negative thought of saying like, I can't do this. Why do I try? I'm a failure. I'm not recommending that anyone has these thoughts, but those would be examples of negative thinking. But of course, if that's the thought that's playing on over repeatedly in someone's mind, like you can imagine, they'll feel sad, they'll feel worried, they'll feel down. And over time that adds up and really affects our mental health and how we live our lives. And so in CBT, we really work to break that down and to address those things going on in our mind. And that's where we see CBT be used in depression, anxiety, and a lot of other conditions, including in psychogenic non-epileptic seizures. I'm not sure how many people have heard about mindfulness-based therapy. And I'll say for some of the other therapies I'm listing, CBT has the most robust evidence base, but there are emerging studies, sometimes smaller scale, looking at these other therapies. And in mindfulness, it's a therapy that's really utilizing tools for relaxation, self-awareness, meditation. And using some of these skills to help us cope in everyday today life. The next one is interpersonal psychotherapy. And again, this one is sort of a cousin to CBT. But in this one, we're looking at like real-time, real-life situations, and we're thinking about how our communication and how our interactions with other people are impacting our mental health, and working on really useful strategies to break that cycle and to improve things in our personal, interpersonal situations to improve our mental health and in the situation to address psychogenic non-epileptic seizures. Psychodynamic therapy is different than the others. It's what people often like classically more think about with psychiatry and with therapy. So in psychodynamic therapy, it's thinking about how to like through more long-term and through more frequent sessions and building trust with your therapist to sort of, it's about like making the unconscious conscious and thinking about things like defense mechanisms, like denial or, if we have like suppressed thoughts and it's really kind of working through those things in therapy. And again, like with some of the other therapies compared to CBT, there's not as much evidence, but there is research going on out there about it. And there can be a role for the right person. There's group therapy, and where the other ones have been individual. Group therapy, it varies by what type of therapy is happening in the group setting, but there are groups. There's prolonged exposure therapy. And with this one, you often think about it with if someone has a history of past trauma, which people often inherent to sequelae of trauma avoid thinking about the past trauma or things that can remind them about that trauma. And so gradually through this therapy, it's about kind of reapproaching that trauma with the goal of processing the thoughts to help improve functioning and mental health. Psychoeducation is different than the other therapies. Psychoeducation, all that means is really going over the relevant information about, this would be like kind of talking about like psychogenic non-epileptic seizures and talking about what they are, what the treatment is, what are risk factors, et cetera. And just giving a lot of that core information to make sure people are really understanding the process at hand. And I included other just because when you look up treatments and therapies for psychogenic non-epileptic seizures in the literature, there's a lot out there going on, which is great because people are looking for answers. People are looking for ways to help progress through having these and get back to living life without the presence of these psychogenic non-epileptic seizures. There's some people looking at EMDR, which is a therapy modality used in PTSD and a lot of other things. And then this one, CBT informed psychotherapy. So what this is a kind of psychotherapy where they incorporate elements of CBT and some other modalities as well. And I mention it because I don't know if any of you are familiar there, if you've looked at books out there about psychogenic non-epileptic seizures. There's many books. Some are written by people with a lived experience of psychogenic non-epileptic seizures. Some are written by clinicians. The one that I'm the most familiar with clinically is a book by Dr. LaFrance, who's one of the leading researchers in psychogenic non-epileptic seizures. And he actually has a workbook that there's one that people with psychogenic non-epileptic seizures can use, and there's one that therapists can use. And it's a very modular, I think it's 11 or 12 weeks course. And that actually is CBT informed psychotherapy. It's sort of like a manual. It's not meant to be a self-help book. It's meant to be a clinical book to use in therapy. But there's elements of CBT, there's elements of mindfulness, interpersonal therapy, and a lot of psychoeducation built in. And it's, I have no stock in the book or anything like that, but it is something that clinically that there is research about and that some people use. And then lastly, so outside of these kind of therapies or this psychoeducation, there is just really tailoring the treatment depending on psychiatric comorbidity or what other psychiatric conditions one might have, which is the next slide. And it's so important to know about this. So common things that you can see associated with these types of events are depression, anxiety, somatic symptom disorder. And I should add, I think, I'm happy at the end to talk about like what is depression or what is anxiety. But I will say somatic symptom disorder is something that can be less commonly known about. And so somatic symptom disorder is it's a symptom that's causing like extensive time spent reading about it or researching, and it's causing impairment in someone's life that isn't better medically explained by another process. And so that's something that we can see as a comorbidity. Personality disorders, so you can also see PTSD and dissociative disorders. So moving to the next slide, so looking at common questions about psychogenic non-epileptic seizures. And this one I've been asked many times, and this is why I chose to answer this question first is, are my events real? And 100% the events are real. I wish I didn't need to say that, but I think it's one of the questions that I think when people wait to ask it or, ask it at a second appointment, I wish I was always just asked up front, yes, the events are 100% real. It isn't epilepsy, but it is, psychogenic non-epileptic seizures. They are real. Another one that I wanted to start with, because I've been asked this one before too, do doctors think I'm doing this on purpose? And the answer is no. That, it's and in the explanation, these are events that no one is trying to have this event happen. But it's a medical illness. It's a condition. It's just as real as epilepsy. Are there triggers? So yes, there are, and everyone's triggers are different. And that's something that I really encourage people to talk about to their doctors about and to be self-reflective about when seizures or events do happen, about what could have been going on. For some people, it could be related to emotion, right? Like sadness, anxiety. For some people, it could be, after an argument or after, some other stressor going on. For some people, it could be more physiologic, like if someone's having a lot of hunger or having like other things, it's, everyone's different. And I just recommend being like open-minded and reflective and communicative with your treatment team. What age do they begin? So they can begin anytime. Typically in the 30s is more common, but they, these events can happen in children. They can happen in the 70s or 80s. It's really anywhere across the lifespan. Are psychogenic non-epileptic seizures dangerous? And so, I think this is a bit of a vague question. because, I think anytime anyone is having like a seizure event, regardless of etiology, you want to be mindful of safety during the event and talk to your clinician or support system about what that looks like, just for depending on the movement types. But in the bigger picture, there is an increased mortality or risk of death associated with psychogenic non-epileptic seizures. And there was a study a few years back that came out with this seizure subtype actually having a mortality risk similar to treatment-resistant epilepsy. And to me, as a clinician, what that means is that, like we need good treatment. We need to communicate to people what the condition is, so that we can really talk then about next steps and how to move forward in treatment, to both, talk about, reducing seizure frequency, but also about how to, have a good quality of life and then keep on doing what you want to be doing in life despite this. Are there driving restrictions? And again, yes, states vary. I work in Maine, so I'm more familiar with Maine's. This is something that I'd encourage, someone, if they're wondering about this, to talk to your provider about it. In the state of Maine, it varies about if it's suspected but not confirmed psychogenic non-epileptic seizures, or if it is confirmed. And even when it is confirmed, then it depends on there's still some nuances within the Maine DMV guidelines. So it's something that people can talk to their providers about. What should someone tell their friends or family? Which is also an important question. And, foremost, it matters what each person feels comfortable with talking about with their friends or family. But if that's something that they're looking to talk about, it can be so helpful to talk to providers about this, to find ways to explain, what is the condition, what is treatment. If someone is having a psychogenic non-epileptic seizure, what do friends or family do to support them or promote safety, or, what if events look different? Those are all questions that people can talk to their providers about, and also talk with friends or family about too, to make sure everyone is aligned. Just because as much as people going through the diagnosis of psychogenic non-epileptic seizures, they have their own experience. But, often this diagnosis comes after years of an epilepsy diagnosis. And if that's the case, then also the friends and the family have had sort of that framework too about how to, support them. And so, again, just having clear communication and getting information from your treatment provider can be so helpful. And again, I think I guess I covered this question a little bit already, but again, talking to your provider about this, because event types or psychogenic non-epileptic seizure events, those can all, one person's can look different than someone else's versus someone else's. And again, that's why it's person specific. And I just encourage talking to your provider, just for knowing that you can and should ask for guidance. And then how does someone know if treatment's working? And again, this is patient specific and something to talk to your provider about. But some people might look at seizure frequency, intensity, but also look at, like what's functioning like what are your goals in life outside of the psychogenic non-epileptic seizure frequency? Like what about goals about functioning, like school, volunteering, home life, work? You can set goals that are also based in someone living their life. And so this is, I think this is my last slide. And so just, everyone's different in how they prepare for an appointment. But I guess I would just consider, how you prepare for an appointment, or if you do. And, I think sometimes at appointments, it's easy to forget questions for everyone. So, I just encourage writing down questions beforehand. Think about where you keep the questions. If it's on your phone, people are more likely to bring that with them. But if it's on a notebook, try to set a reminder to bring it with you. And if you feel comfortable, you could think about asking kind of like your supports if they have any questions that they'd want you to ask, just in certain terms of like the bigger system of your support network. Consider talking to your provider if they'd recommend that you keep a log or a journal about event types. I think, I can't speak for any specific person or their specific provider, but it is a question. And then also, like in the log, should you be thinking about triggers? And this one I can't stress enough. If you're not sure if the diagnosis makes sense or feels accurate, please ask questions and explain your concerns. Because again, like I mentioned, an earlier acceptance of the diagnosis is better linked prognostically. And so really, if you're having doubts, please share them. And just ask about treatment options, share what you've tried before, and give any feedback about how it's going. Talk about what's worked, what hasn't worked. And, if you have questions about like logistics or anything, I just always encourage, self-advocacy. And then lastly, so if someone establishes care with a therapist or a psychiatrist, consider asking your providers about care coordination and how to communicate a treatment plan relating to psychogenic non-epileptic seizures. And I say this because everyone who does therapy, or I guess I should say, people who do therapy have different training backgrounds. Some are physicians, some are psychologists, some are nurse practitioners, some are PAs, some are social workers of different like training backgrounds. And so, different people's exposures to psychogenic non-epileptic seizures and training could be different. And that's where, I just really encourage, coordinating care. And, like if you have a plan or someone has a plan with their neurologist about if this seizure type happens, do this. If this seizure type happens, do that. I would just encourage including the therapist in that conversation and the PCP too, just to make sure everyone's on the same page and can really, feel confident in pursuing the next steps of treatment. And so I only made a couple of references inside of the PowerPoint, so those are there. And next, that's it. So if there are questions, I can stop sharing my screen.
There are, and I'm happy to read them to you. Dr.
Whatever
Taplinger.
one.
So sorry if this is a silly question, and I think I should know the answer when I also replied to that there are no silly questions. But I feel like epileptic seizures can damage the brain, especially seizures with hypoxia. Is damage to the brain something that you see with PNEs?
So I will agree, there are no silly questions. I welcome all questions. And I think, I also say as a clinician, I'm an eternal learner too, even though I've been in attending for years now. And so for that one, I think that's a good question for the neurologist. In my experience, the research about brain functioning and some of the functional studies have been more looking at like risk factors for developing or like patterns of brain functioning that might be associated with psychogenic non-epileptic seizures. I haven't seen that in the literature myself. And so I would just encourage asking your neurologist at the next visit. But I haven't seen that.
The next question that we have is there a higher mortality rate with this type of seizures due to physical accidents, or can people with non-epileptic seizures die from SUDEP?
Yeah, so there is when they did a breakdown in that study, there was like an unknown section. There was a risk of like risk of injuries related to seizures, but there's also like elevated risk of suicide, and I think that speaks to the mental health comorbidity there as well. So there isn't that direct relationship with the SUDEP, but there is also an unknown section of to why there is increased mortality. And that's something again where I think, if mortality is higher, for all the other reasons that we encourage treatment, but also with increased mortality, these events, these seizures need treatment. I think like one other thing I might add there is that in psychogenic non-epileptic seizures, before the diagnosis is made, you can see people, being treated for physiologic or epileptic seizures with multiple medications. There can be a risk of intubation. And so there is a lot of medical risk if we're treating a type of seizure that isn't there. And I don't mean to say that I think the physician or the provider I'd expect is doing their best because it's a really challenging diagnosis. And until the diagnosis is made, they would be using those medications, presumably. So it just, I think it's a big area of research.
Thank you so much, Dr. Taplinger, for spending this time with us and speaking so much about a topic that we come across a lot in our work with families. I do want to reiterate that we do have a support group, share group. We have weekly for PNES. It happens. I did put it in the chat, but it hosts weekly on Mondays from 7 to 8:30, and it is virtual. So there is a link right there to register. So if you are interested in attending that group, the group is again individuals impacted by PNES and being able to connect with others who maybe are going through some of the same things you're going through, because it can be a real struggle. And one of the things, like Dr. Tablinger reiterated, was that, no, you're not faking. So a lot of the times, we get that a lot from our families saying that. So again, we want to reiterate that we're here to help and support you and connect you with resources like Dr. Tablinger and other resources that are there. So please reach out. But thank you so much, Dr. Tablinger, for such a lovely presentation and information. It was very, very well done. So thank you so much for your time with us today.
Thank you so much for having me. I really appreciate it.
Thank you. Now I'm just going to go ahead and take about a 10-minute break. So that way people can get up and get what they need and have a break and stretch their legs, because these conversations are long and I have my friend in the background walking on my counter. I'm going to go ahead and we'll resume back at 11:55 a.m. I'm going to go ahead and just kind of take off my video and mute. But happy to have you guys back at 11:55 with Dr. Benjamin Drapko, who will be talking about epilepsy management and understanding traumatic brain injury and epilepsy at the same time. So thank you guys so much and look forward to having you back. Resume our recording so that way we have the ability to have these to share after today's day. So thank you so much for joining us, Dr. Drapko.
Thank you for that kind introduction. Are you able to hear me okay?
Yes, I can hear you just fine.
And I'm not dressed down. It's not showing up so well on the video, but I have my epilepsy.com t-shirt with my purple brain. Otherwise, for this context, I might have worn something with a collar, but I wanted to represent the Epilepsy Foundation. So the purpose of my talk is really focused on new therapies in epilepsy and trying to strike a tone of kind of optimism and hope that we can always do more. I see something in the chat. Let me make sure there's, thank you. Yes, gotta have the brand. I have some socks too, but I won't show anybody those socks today. I know that there is some interest in discussing traumatic brain injury related epilepsy, and I don't have dedicated slides to that because so much of the treatment for traumatic brain related epilepsy is similar to focal epilepsy or other epilepsies that are caused by an injury to one part of the brain. But because I don't have dedicated slides about that, and I know that was an area of interest, I actually am happy to just field questions about that right up front and see if there's anything in particular about traumatic brain injury you'd like me to touch on as I go over these therapies. Everybody seeing the slides okay? So please interrupt with any questions about the traumatic brain injury aspect of this. I wanted to recognize the Epilepsy Foundation for being really a whole resource for my family, an asset for my sister. This is her after running the New York Marathon for the Epilepsy Foundation. I have beads on and didn't do much running other than to catch her at the finish line. So shout out to her. But yeah, it's been a big part of our lives. So any questions to start about medications, about surgery, fears about the future of treatment or concerns or hopes? I'm happy to hear anything from patients or other providers on the call. Please just interrupt as they come up. Oh, hi, Joey.
Hey, I was gonna ask, do you know about the stem cell therapy that's starting to be used in, like, I think it's mesial temporal sclerosis or something? I think is it?
I won't pretend to be an expert on that topic. What have you heard about it, or what curiosities do you have about it?
I was just wondering, I know someone brought it up, one of the neurosurgeons at a recent conference, and they said it's now they're accepting patients for a different, it wasn't mesial temporal sclerosis, it was like a different, same region. I forget exactly what it was, but I didn't know if, I feel like that's one of the up and coming ones.
Yeah, I'll talk about epilepsy surgery a little bit at the end, and I can kind of incorporate that into some of that discussion. I think the concept with stem cells would be using kind of undifferentiated cells that might be able to develop to kind of replace injured tissue rather than taking it out. It's interesting, but there's a whole lot of immune reactions with stem cells, and you have to be really careful in introducing new cell types into same thing you do transplants or anything like that for kidney disease, things like that. I would say that it's exciting to think about. I would also say that if we are able to really kind of pinpoint where seizures are coming from and get a sense of a person's strengths and weaknesses, we are often able to intervene on an injured part of the brain where seizures are coming from, either with stimulation or with surgery. And our brains are so redundant that often you can lose a little bit of your brain and still not lose who you are and your functioning and get better control of epilepsy. So while stem cells are exciting and the idea of replacing tissue is exciting, our brains are so complicated and resilient, and oftentimes we can still work around losing a little bit of brain tissue if we prove that we need to for epilepsy. And the use of zebrafish in epilepsy research. I can't pretend I have every last study of that down. I actually did some research doing learning behavior in zebrafish actually in a lab in Brown when I was a college student, just trying to get my foot in the door for research. Zebrafish are well studied, that you can make gene changes, and we know what their behavior is like, and they're an animal where you can make alterations to their environment or to their genes, and really closely study how it changes them. Another question here. Yes. My role back in the day was not changing the genes or treating seizures. That was using fish to see if they learned their environment. I was designing little PowerPoint slides and backgrounds for the fish to swim in, and see if they settled in when they were in a familiar environment versus would bounce off the walls when they were in under stress or exposed to chemicals and things like that. So basic science does inform a lot of this, but it takes years to bring it up to the point of having a new medication to market or anything like that. So I appreciate everybody's curiosity. I will just kind of provide a bit of a overview for things I'm going to cover today. Development of medications over time is one. Things beyond medication treatment, including surgeries, and then just general questions about the future treatment of epilepsy. So just kind of breaking epilepsy down by type of seizure. Many patients that continue to have seizures in adult life have focal seizures or seizures coming from one part of the brain that can then spread. Those will have different symptoms based on what part of the brain the seizures are coming from. If you have seizures from the part of the brain that's responsible for memory, you might get deja vu, or if it's coming from the back of the brain, the occipital lobe where vision is, you might get visual changes as part of your seizure. So focal epilepsy is often the predominant type that persists into adulthood, but not always. A lot of patients that have generalized epilepsy is an epilepsy that involves a broad region of the brain all at once, and that's usually caused by some sort of genetic condition that puts the whole brain at risk of this short circuit. But those are more common in childhood, and some patients experience improvement in those seizures as they age, but not always. Some patients with generalized epilepsy require treatment with devices and medications into adulthood. And then a high prominence of non-epileptic seizures are seen in patients with epilepsy. It's a dual diagnosis. I think the connection would be that, you know, trauma and stress and anxiety are things that can come along with having epilepsy. It can put you at risk of having non-epileptic seizures, and epilepsy itself is a stressor to a lot of people. My overall tone of today's talk should be that there are more things in the future, and we can always do better. And epilepsy is something that, you know, patients might struggle with, but can also come with a lot of strengths and strong community support, and patients with epilepsy can do quite well. But it is important to acknowledge that it can be a struggle, and counter my positivity with a realistic take that this can be a big stressor, and trying to treat both the epilepsy and the mental health aspects of epilepsy are really important to us. And then, yes, some other specific types of epilepsy that tend to be more severe are epilepsy associated with other genetic conditions where you'll get multiple seizure types and be refractory to medication. Things like Dravet syndrome and Lennox-Gastaut. These type of syndromes often have an underlying brain lesion associated with them, and they're the area of a lot of research. These types of epilepsy syndromes often drive some of the newest medications that come to market that can then be eventually expanded upon and used for other patients without these severe syndromes. We've talked a little bit already about the ketogenic diet today from Dr. McDonough. I wanted to take at least a second to recognize that beyond medications and surgeries and treatments, you know, I heard Dr. Salvatelli talking about exercise this morning as well. Kind of holistic care matters. Patients can have fluctuations in their seizures without changing their medications or changing anything else about their treatment other than settling into a routine, getting better sleep, you know, having more support, are the things that your grandma told you to do in terms of sleep and exercise and eat right and wear a jacket when it's too cold outside. Grandma was right. So there's things we can do beyond just medication to try and support people. I think Dr. Taplinger already spoke about non-epileptic seizures in detail, so I will be brief here, but I think my view of this is that understanding the diagnosis and having a conversation where patients and the provider are on the same page is really the number one step, and having insight into these symptoms and empowering patients to be part of the process of kind of getting a control of reality and reeling back in when you're starting to feel your brain kind of shut down, and making patients part of the process is really the number one step. And non-epileptic seizures have a very positive prognosis. Patients are able to do better over time, and the first step is identifying this diagnosis and normalizing it for patients, since it is a fairly new concept and has had stigma in the past, and it's on us to really normalize this process for people. Anti-seizure medications over time. So the very first was potassium bromide. Phenobarbital was found in the early 1900s. And you can see kind of an explosion after the 50s and 60s. A lot of this was kind of making a national system for drug development, where we would, test different scientific compounds on animals and figure out which part of the brain or which part of a cell they are acting on. A lot of anti-seizure medications tend to work on, I don't want to get too much into the science, but your brain cells communicate with each other through electricity. All of the way we move and speak and talk is related to electrical signals within the brain, sort of like a computer. And the way that electricity is created is by moving ions or electrolytes around in your brain. It's like a circuit. One cell will activate, and then it'll trigger the next cell down the line to activate. And once a cell activates or fires and communicates with its neighbor, it is usually supposed to kind of reset and be on a sort of schedule. And seizures are caused by too much electricity, or instead of firing and resetting, a brain cell will fire repeatedly, and a sort of electrical short circuit will turn into sort of an electrical storm. And these medications are working on either kind of calming down the signal that fires, or ramping up the part of the brain that resets after a brain cell has fired. Your brain kind of has an exciting part of it and an inhibiting part of it. So we can either ramp down the excitement or ramp up the inhibition. So got some fancy presentation for PowerPoint here, but this list is growing all the time, and many of these medications are, working on 4 or 5 different targets in the brain. There are only so many targets we know of: the sodium channel or the GABA channel, or other targets or other signals within the brain. But over time, we found new targets, and we found medications that hit similar targets with a lower side effect profile. So I took over care from a lot of Dr. Hettinger's patients, and she practiced for over 20 years. And I've inherited patients that are on medications that, from my training, being a recent trainee, are thought to be sort of old school, so to speak. The old school medications can work quite well. Sometimes they have more of a side effect profile that makes us want to switch to a cousin, a newer medication with lower side effects. But not always. The right mix of medication for each patient is individualized. We try to kind of use one medication first and see if you can be seizure free, and if not, we add to the mix slowly. When we add new medications, we try to use different targets in the brain to avoid having overlap and side effects. And oftentimes we are able to get things right with medications. I see a question in the chat. Excellent. So Morgan asked about migraines related to a focal seizure, or a mimic. So that's a great question, and there is not a simple answer to it. So migraine and seizure oftentimes can fool us. There's times where you'll have symptoms that could be flashing lights or sound sensitivity, even becoming briefly confused. And the question of is this a seizure or is this a migraine is not always clear. We don't even have a great sense of definitively what causes migraines. There are theories that they're related to blood flow in the brain or electrical activity. Migraines do not cause long-term damage and do not respond to treatment like seizures, but there can be a lot of overlap. Seizures usually, we can tell that they're different than migraines because they're usually shorter and stereotyped and repetitive. You'll have the same symptoms every time for a seizure versus a migraine might be kind of waxing and waning symptoms, longer duration of symptoms, hopefully associated with a headache to help distinguish it. The question is not always clear. Sometimes we have to try and treat for seizure or try and treat for migraine and see if it gets better. Or sometimes doing an EEG and seeing if you have those symptoms on EEG, do we see a seizure or not, can help us be in one direction or another. Also, migraines probably are more common in patients with epilepsy. There's something about a brain that is hyper-excitable that could put you at risk of both. So, it's a common question and something we often will take a couple of visits to really suss out with patients, try and pick one direction or another. And sometimes we end up treating for both if it seems like both are present. So that's a great question. Yes, so this is a question. Joey, excellent. So that is an excellent question, Joey, about kind of like how we pick medications. I'll go back another slide for this. This is a very individualized question. Many of the medications on this list are effective for focal versus generalized seizures. Many of them have similar seizure control overall, and trying to choose the best agent for each patient really is a matter of what type of seizure, but a lot of it is what comorbidities does a patient have. If a patient is experiencing a lot of headaches, some medications, zonisamide or topiramate or lamotrigine might help with headaches. If someone has trouble with weight, some medications can help with weight loss. If patients have trouble with appetite or low weight, some can help with weight gain. Some of the medications are better for mood and some of them are more mood neutral. Some medications are more like you don't really feel it and it helps with seizure control and it doesn't have a lot of other effects otherwise. In general, I usually, and I think all of us at Maine really try to practice shared decision making with patients where we view ourselves as giving you advice and patients ultimately making a decision with the doctor. I like to try and give people a couple of options and have them choose, since oftentimes there is not a single right answer, or you could pick 2 or 3 different options and they'd all be reasonable options. And patient preference is part of it. Oftentimes we'll start with the medications with the lowest side effect profile, Keppra or Vimpat or lamotrigine. Oxcarbazepine is another one that's pretty well tolerated. We'll kind of start with some frontline medications, and then usually we try to maximize one medication and increase the dose first before adding a second, and go one step at a time. It's complicated and it's individualized, and I really try to give people the power to help make decisions, and also the encouragement that sometimes we don't know for sure, and it sometimes takes a little bit of time to get it right. And we're always willing to work with people to try one thing, and if it doesn't work, switch to something else. There are so many options here, and what works for one person might not work for another person with similar epilepsy. And there's probably genetics about who responds to what medication that we still need to understand better. So it's a complicated process, but I would say that we have so many options available these days. Usually we're able to find a mix that most people can tolerate. So this is a little bit of a humbling graphic here in terms of if patients aren't able to be seizure-free with one medication, we always do try to maximize, and we'll add 2 or 3 or even 4. Some patients are even on 5, which is a lot to handle. And there's always improved seizure control with adding medications, but the likelihood of getting complete seizure cure and freedom does diminish as you add medications. Oftentimes, if patients are going to be refractory to 2 medications, they're likely to be refractory to a third, and that doesn't necessarily mean that refractory means that we have to do more than medications. If patients are refractory, it means that they're still having seizures, but not every seizure is created equal. If patients are having rare seizures where they feel symptoms but don't lose awareness, don't hurt themselves, don't fall, then that's not necessarily epilepsy, or we need to go from medications to considering surgery. Some patients can still have rare breakthrough seizures and have an excellent quality of life. And our goal is really to find the quality of life rather than suppressing every last seizure. But if the seizures are debilitating after 2 medications, or still causing loss of awareness or impacting people's quality of life, then it really is on us to be open with patients and say, the likelihood we're going to completely suppress seizures with medications alone is low, and we need to explore other options. The standard of care, if patients are not getting control with multiple medications, is to consider epilepsy surgery or epilepsy stimulator devices for further care. And that's something I like to say openly with patients, and not as a negative thing, but just as a way of offering more to do. There's always more we can do. You got a comment here? Oh, thank you, Kristen. So this is perhaps a little bit dramatic, and the old black and white photo helps have that effect. But this is important to recognize. I know what medications work for patients, and as a provider, I'm biased to hear that there are seizures and say we need to control them better. I'm not the one taking the medication and living with the side effects. Oftentimes, patients will say that our goal is complete seizure freedom, and their goal is, balancing seizure control with their side effects. And sometimes what we think is the goal as a provider is not the patient's goal. So we have to be mindful that, a lot of these medications work quite well, and we can often find a dose that's tolerable, but all of them do alter the way your brain works and have some potential side effects. And it's not trivial to say, yeah, take a second or a third medication. And even the act of going to the pharmacy every month and picking it up and remembering to take it, along with our busy lives in 2024, we're mindful that it requires sacrifice and investment from patients to be on medications. I think I've kind of spoken to this sort of balancing act here between side effects and seizures, and hopefully we can get everything just right. Sometimes we do have to pick one direction or another and either tolerate a little bit more side effects or tolerate a little bit more seizures. The bottom line is in the middle, what quality of life. I'm going to actually go through some of these new medications in a little bit of cursory detail. I want to spend some time to talk about surgery, and the specifics of these medications really are best discussed with each individual patient and your provider. But I'll kind of at least name some of the new agents on the market and talk about the highlights of them. Xcopri or cenobamate is a very effective medication. It's one of the newest medications to come to the market. It works on multiple targets in the brain. It is a medication where people have been refractory to 2 or 3 other medications, and they start this and their seizures get much better controlled. It can be a tough medication to tolerate in terms of sedation and dizziness. It is definitely a strong medication. So we try to find maximum dose that patients can tolerate without side effects. And oftentimes we even need to kind of back off on doses of other medications while we start this medication. But it's worth it because this is an effective medication. And we're still kind of determining some of the best doses and the long-term tolerability of this medication. The initial data suggested trying to push patients on as high of a dose as possible, up to even 400 milligrams daily. And some patients do respond better to higher doses. We're learning over time that lower doses of this medication can still be quite effective. And if patients aren't able to tolerate the higher dose, we try to find the highest dose that they can tolerate in terms of side effects and find that it is still effective for seizures. CBD, this is not like CBD you'll see at the, I guess they're in grocery stores or gas stations now, but this is not the low dose CBD that's sold for pain or anxiety or related to like dispensaries. This is, high concentrated medication grade CBD that is not necessarily all that different from another medication in terms of the concentration and the potential side effects on the liver and things like that. I like to have optimism that this can be an effective agent for patients with epilepsy syndromes. It's approved for Lennox-Gastaut syndrome. It can be very effective. I do want to be honest that it is more or less a medication like all of the rest, rather than something that people like to think is natural or different than other medications. And at this strength, it really is. I consider it just like any of the other medications on the list, but it can be quite effective. I just prescribed it earlier this week with pharmacy's help for a patient that had a hard time with other medications, and I definitely believe it is a strong option. But it has to be viewed as a medication that requires lab monitoring, just like anything else. And this is some of the background for how it was developed. It's still only approved for patients with epilepsy syndromes, though we're starting to use it a little bit more broadly and expand some of the indications for this medication. I'm going to go over some of these other medications fast and save time for seizures. Steripental is another medication approved for Dravet syndrome that can be quite effective in patients that otherwise don't get good response to a lot of other medications. Fintepla or fenfluramine is a medication that can be effective for patients with refractory epilepsy. It is a medication that works on serotonin, which is a neurotransmitter or a hormone that a lot of the other medications don't affect. Serotonin is also the target of a lot of medications for anxiety and depression. Because this is a slightly different way the medication works, it can have side effects that are unique too, and it can actually affect the heart valve function and the pressure in the arteries to the lungs. So this is a medication that we don't start lightly. The side effect profile is strong, but the potential seizure control is strong because it's so different than other agents. So we will use this in patients that are not doing well with other options. And we have to keep a very close eye on them with cardiac ultrasounds or echocardiograms that look at the pressure in the arteries to the lungs and the function of the heart valves. And as long as that is stable, you can stay on this medication. But if there are changes on the heart function, we often have to stop this medication. So I think this is kind of showing how a lot of these medications are initially studied in patients with refractory epilepsy syndromes and then expanded. Out of these novel agents we've discussed from the last several years, I think Xcopri or cenobamate is the one that we're using most broadly and is an option for almost any patient. Though we will probably start some of the less sedating, cheaper options first and use this medication for patients that aren't responding to some of our more typical first-line medications. So here is some of the kind of theory about epilepsy surgery, transitioning from medications to surgery. I think I've got about 10 minutes here, and it's going to be hard to cover all of this in 10 minutes, so please interrupt if you have thoughts. But overall, epilepsy surgery is for patients that are not responding to medications. In order to treat with epilepsy surgery, you have to think kind of like real estate, like location, location, location. If we are able to determine that seizures are coming from one place, then you are able to treat that one place. And the options include doing a resection to take that part of the brain out. That is the most effective intervention if we can prove that the seizures are coming from one place, and if we can also do testing that tells us that that part of the brain is not an integral part to a patient's movement, speech, memory, personality. If that part of the brain is proven to be dysfunctional and not contributing to somebody's quality of life, then we are able to take, you can take out an entire temporal lobe if a patient has their language and memory on the other side and cure their epilepsy. And patients will have very minor problems with speech that are often rehabable with focused speech therapy. It is honestly kind of wild to say that we could take out a part of the brain to cure epilepsy and patients can do okay afterwards. But it's one of the most profound interventions we can make. Other options are to do, if they're worried about the surrounding area near the area where seizures are coming from being critical, and we don't want to take out too much of the brain, you can use things like a laser to try and scar down the area where the seizures are coming from, and you don't have to do as much of a surgical resection. And then if patients aren't candidates for being able to take out or use a laser to treat that one part of the brain where seizures are coming from, there are other interventions that can still be effective. So epilepsy surgery is not just for patients with seizures coming from one place. If seizures are coming from both sides of the brain, and the most dangerous seizures occur when patients have seizures that spread from the left to the right, you can do a procedure called a callosotomy, which actually removes some of the connective tissue right down the middle of the brain that connects the left and the right hemisphere. Those surgeries can cause some minor changes in cognition, but that part of the brain is more for communicating from one side to the other and doesn't have that much of its own function. So patients with refractory seizures can still get very good benefit from that procedure. And then the new age and the whole new world that we're still learning more about is stimulating devices. There's honestly, any sort of stimulation to the brain can decrease seizure frequency. There's something about adding electricity to the brain that either is a noxious stimuli to the brain that tells the brain to stop seizing, like a slap on the wrist, or there's theories that stimulating the brain causes the whole network to reset, and that the kind of short circuit that causes seizures can be broken up by stimulating the whole brain. And there are multiple different devices that can help either stimulate the whole brain or a certain part of the brain where we think seizures are coming from, or a deep part of the brain that is involved in coordinating all brain activity and can redirect seizures. I see a chat question. Elsa. Not a silly question. No such thing as a silly question. Maintaining shorter hair is better for people with epilepsy. I don't know if that's because longer hair makes it more difficult to have EEG electrodes placed, or if you're going to do epilepsy surgery, sometimes you do need to shave part of your hair. I don't think there is much scientific data that suggests that shorter hair is better for seizure control. And in general, I really would empower people to be the individuals they are. And as a doctor, it almost makes me uncomfortable about trying to tell someone about their appearance or how they look. Especially as a male doctor, trying to tell anyone what to do with their appearance. I'm very sensitive to that. It's a new age in medicine, and we have to allow people to be the person they want to be. I've been getting the same haircut since I was like 12 years old, so I'm the wrong person to go to about style. But thank you for your question. So I want to just kind of go over some of the different surgical treatment options, and I should wrap up and leave some time for questions too. This is a cartoon diagram of what it might look like to take out part of the temporal lobe. This is one of the best studied epilepsy procedures is temporal lobectomy that can be quite effective if seizures are coming from that area. This is a cartoon of that corpus callosotomy, which uses often now it's a laser rather than a scalpel that can get rid of some of this connective tissue between the left and the right and prevent seizures from spreading. Laser ablation refers to using a laser on the outside of the brain to try and scar down the area where seizures are coming from. We're able to target the laser with 3D modeling and using advanced MRI to make sure that it's delivered right to the place you're trying to get to. If someone has temporal lobe epilepsy, oftentimes doing the complete surgical resection is slightly more likely to cause cure. But if there's concern about memory or speech, the laser can often get get very close to similar seizure control without having to take out that part of the brain. That is an individual decision to make with us and with your neurosurgeon you would meet with if this is something you've ever considered personally. I'm going to skip through some of this a little bit. Vagal, or in order to have either a surgical resection, a laser ablation, or a neurostimulator that is inside of the brain, we need to really define where seizures are coming from, and that really, in most cases, necessitates doing EEG testing against the brain surface itself. So our phase 1 EEG is the EEG many of you have probably undergone if you're patients, and that's the electrodes on the outside of the scalp. Once we are able to kind of use that EEG to figure out in general where seizures might be coming from, that kind of gives us an overview. We often need to do a zoomed in evaluation to see exactly, the scalp EEG might tell us it's the right temporal lobe seizures are coming from, but doing EEG testing with the electrodes against the brain surface itself can tell us exactly in the right temporal lobe where seizures start and spread and give us a better boundary if we're going to be considering stimulating the brain or resecting part of the brain. The cartoon drawing on the left shows kind of electrodes overlying the surface of the brain, and that's how this was initially done, opening up the skull, doing a surgery, and then implanting electrodes on the surface of the brain. That is still done sometimes. The newer age training is to not have to take the skull off and use electrodes that are placed with a robot through the skull. It's wild that we can do this, but this is the standard of care. I did this on many patients when I was training at Dartmouth, and it's a combined approach between neurology and neurosurgery. And these don't cover the surface like the strips and grids do. They go deep to the target. So one electrode will have, or one wire will have multiple channels, and on the way down, we're sampling the brain. This doesn't give us a picture of the entire brain, so we have to start with the scalp electrodes, but this gives us a high definition picture of where seizures are coming from. I saw another chat question. Yes, so for Kimberly, EEG can show seizure activity while on medications. The medications can sometimes lower the chance that we'll see activity on an EEG, but not always. And sometimes there's if we're just seeing the short circuit discharges that tell us a risk of epilepsy, that doesn't necessarily mean we need to change your medications. You don't want to treat the study, so to speak, but sometimes we're able to say that that's a marker that we need to change medications. It kind of depends on how a patient's doing in terms of their symptoms too. If a patient's seizure free and they have an abnormal EEG, we need to be careful, but you don't have to necessarily treat that. If a patient's not seizure free and they have an abnormal EEG, that tells us we need to be a little more aggressive. And Joey, your question about stereo EEG in a patient with known generalized epilepsy. So this is a nuanced question, excellent question. It's saying if we think seizures are coming from all over the place, is there a reason to do EEG looking at one specific target? I would say that in theory, if you all of your data suggests that it is a generalized epilepsy and there is no concern for a different type of epilepsy or a different type of seizure that could be from one focus, then you may not do stereo EEG. But generalized epilepsy patients can also still have traumatic brain injuries or strokes or something else that causes a focal epilepsy. And you can have both a generalized and a focal epilepsy. So there are times where patients with generalized epilepsy will still get evaluation with stereo EEG looking for one seizure focus. That's a complicated question. That doesn't happen too often, but it is possible in theory. I'm running a little bit out of time. I just want to show the cartoons for these devices and then take some questions. So the first device that was implemented was a vagal nerve stimulator. It's still very effective. We still have many patients with them. This treats the whole brain by stimulating the vagus nerve in the neck, which causes a calming signal to the brain stem and throughout the rest of the brain. This can redirect seizure activity over time. Sometimes activating this device in the middle of a seizure can help shorten the seizure as well. This can work for generalized or focal epilepsy. It does not always require the intracranial monitoring that the other stimulators do. It can be effective. It is not typically a cure. It usually requires staying on some form of medication. But these are very effective and probably the simplest of all these options. I'm going to skip this a little bit. The RNS, or the neural pace system, so a pacemaker for the heart is kind of the analogy to this. A pacemaker for the heart has a wire that detects the heart rate rhythm, a computer that reads the heart rate rhythm and interprets it, and then an output wire that shocks the heart to redirect it if it sees a rhythm it doesn't like. This is like a pacemaker for the brain. It has an electrode that reads EEG activity, a computer that recognizes when a seizure is happening, and an output electrode that causes a stimulation at the site of seizures to try and disrupt the seizure from happening. These are used most often for focal epilepsy, though they are also being used for generalized epilepsy now by stimulating the deep part of the brain. Like it's sort of the relay center for brain activity, the thalamus. Here's an example of the electrode detecting a seizure and applying a shock. They're programmed in the office, and we work closely with engineers to try and identify the electrical signature of a seizure and find the best stimulation parameters for patients. This is something I work closely with engineers from the company on, and it's a group decision between the patient, me, and the engineer about how to change their settings. A deep brain stimulator is sort of like a hybrid between the RNS and the vagal nerve stimulator. The vagal nerve stimulator has a battery in the chest and a wire in the neck. The neural pace system has a battery implanted at the skull and wires in the brain. The deep brain stimulator has a battery in the chest and wires implanted in the brain. So this works similar to the vagus nerve stimulator in that it just provides a charge on a set schedule, and rather than the RNS that provides a charge when it detects a seizure. This device is more treating the whole brain all at once by stimulating the thalamus. It is slightly perhaps more effective than a vagal nerve stimulator because it's stimulating the brain itself rather than the nerve in the neck, though it is a bit more invasive. We have patients at Maine Medical Center with all of these devices. We've had patients getting surgical resections. I think all of these options I've discussed are strong options for patients that aren't getting the control they would like with medications. And it's a process of meeting patients where they are and figuring out which option works best for them. I want to get to my thank yous and be open for questions. So I wanted to just recognize our whole team in the epilepsy clinic. I see many of you on here today and really appreciate the support. Our patients and their families and parents aren't on here. I should have included that. I know some of my patients are listening and really appreciate that. I wanted to take a second to recognize Dr. Henninger. I know many of you have worked with her in the past, and she has retired, and I'm really honored to be working in her place and have overlapped with her for some time. I learned a lot from her. And then the Dartmouth community Kristen mentioned, Dr. Yobst is kind of a god of epilepsy. Dr. Culler was my direct teacher there at fellowship. And Dr. Greer was a mentor of mine. David Greer is a neurologist in Boston who helped me decide epilepsy as a career. And he was somebody who invested in me when I was young and trying to navigate all of this. So it takes a village to care for a patient with epilepsy. It took a village for me to get here to Maine. I've been here for a little over a year now and feel very fortunate to be here. I love life in Maine and the relationships I've developed with patients so far. So thank you for having me. And why don't I review some of these chat questions and open the floor to anyone else who has other questions too. Mandy, thank you for your question. What percentage of epilepsy patients undergo surgery? I don't have a percentage off the top of my head. I would say that, the numbers are a little higher than we'd like to admit in terms of patients that are refractory to medications. I'd say about a third of patients end up being refractory to medications. That doesn't mean that a third of patients undergo epilepsy surgery. Out of that third of patients that are refractory to medications, a good chunk of them are probably still reasonably controlled enough and not having severe limitations in their life that they need epilepsy surgery evaluation. But if I had to say, maybe 15 or 20% of the patients with epilepsy end up benefiting from a potential epilepsy surgery. I see Kristen's stat about the number of patients who actually get evaluated, but that number is lower than it probably should be. For me, my practice is to bring up the concept of epilepsy surgery early, even if the patients aren't quite there yet. As soon as we're considering starting a third medication, I'm starting to have this process of saying, we're going to aim for the best seizure control we can get with a third medication. And if it doesn't work, we're going to evaluate you for other options. And it's got to really be patient driven too. So that's another thing. Dr. Jobst is a powerful German woman who I can still hear her voice in the back of my head saying, you never are the one to push patients to surgery. You wait for the patient to come to you when it's time for surgery. You inform them of their options, but this is a patient-driven process. Any other questions? Anything else specifically about traumatic brain injury that I didn't touch on that you would like me to? I know Lynn is coming up soon. I can pause and let Lynn get ready to speak too, but I'm happy to field another question or two if you'd like. Yeah, Joe, you've been on fire with the questions. Please, by all means, if you want to unmute and speak, let's hear you.
Yeah, sorry, I probably won't type it as well as I should. For TBIs, I don't know if this is just my limited experience, but when I work with patients who have had them, a lot of times I see them not get epilepsy or have seizures until like long after the accident happened. Is that common? Is that and then kind of, and maybe again, this is just my limited experience, but get worse over time? Is that like a common prognosis, or is that just my experience?
Traumatic brain injury is such a common thing, unfortunately, with our busy lives, and it can be a very tricky condition to treat. I would say that seizures are often even years after a traumatic brain injury. If there's been some sort of injury there, scarring that sets in, sometimes it takes time for the rest of the brain to change and for that short circuit to come out. Actually, a lot of times, if a patient has a seizure right at the time of a traumatic brain injury, it sometimes can just be a symptom of the injury and not a sign of long-term epilepsy. But if the longer it has been since a brain injury that the seizure happens, the more likely it is that there's some long-term scarring or something that's happened that puts a patient at risk of recurrent seizures. One tricky aspect of traumatic brain injury is that often, if you hit your head on the left frontal part of the brain, there's an impact to the brain to the left side, but as you recover, there's also this backwards impact, and you can have a diagonal injury on the right, the posterior part on the right, a coup and contra coup injury is what that's called. So oftentimes, traumatic brain injury causes epilepsy that is multifocal and coming from more than one place. Not always. There's times there's one, a bleed that occurred in one big injury, and traumatic brain injury patients can sometimes be epilepsy surgery candidates, but it sometimes can be multifocal epilepsy. Sometimes it can be more likely to be refractory. Traumatic brain injury often also comes with direct, cognitive symptoms or personality symptoms. If the frontal lobe is injured, patients can develop disinhibited behavior and
so a friend
need
of
to be in
mine
a group home
panics
setting
because
for
he has
care.
to- but then we have
So
to
it can be
reschedule.
tricky, and a traumatic brain injury puts you at risk of having
He has appointments
earlier
at-
age-related
He's like, "Oh,
memory
I'm
changes. So
26." No,
we need to treat
no,
traumatic brain
no,
injury patients for
okay.
epilepsy and provide supportive care and treatment for mood disorder.
I'm
It's
like,
kind of
"Oh, goodness."
multiple conditions wrapped up into one diagnosis. Peter, I saw you unmuted. I wasn't sure if you were trying to ask a question or not. We would absolutely love to hear from you if you have one.
I still love to be island with him so Peter can be alone. Because Peter has to, de-escalate from being with people. Like he seems like he's
I'm having a really hard time hearing you. I heard the word de-escalate. Was this question about kind of agitation around seizures? Would you want to send it in the chat so we can talk about it? I'm sorry, I can't hear you. I think it's probably best that I pause and allow Lynn time. I've gone over a little bit, so I think I'm probably going to end my screen sharing, but we welcome that question, and sorry I didn't get to it. Thank you again to the rest of our team and to Kristen for putting this all together.
Thank you so much, Dr. Drucko, for joining us today. And we are so fortunate to have got you from Dartmouth and to be spending your time with us. Thank you for your knowledge. And thank you also for sharing in the beginning your personal connection with epilepsy. We truly appreciate you sharing that. I think for your patients too and our families, I think it makes a huge difference when the person that's treating us understands and sees how epilepsy impacts the entire family, and that it's not just that person that's going through it. So thank you so much for sharing that, because that brings a lot to our families to know that the person that's taking care of them knows exactly how this impacts the family that's going through it. So thank you so much for sharing that, and thank you so much for being with us today. It's wonderful being able to have you be part of the Maine group now. So thank you so much.
Thank you.
My next presenter is Lynn Nichols, and she is a nurse. She's actually an advanced nurse practitioner at Maine Health. She's part of the Maine Medical Neurology group as well. And she's here. She is a patient navigator and is a huge resource for families. So she's going to speak to us today. I'm so glad to have her and talk about what is a patient navigator and what is their role and how can that help you. So thank you so much, Lynn, for being here today. And I'll go ahead and pass the mic to you.
Sounds good. Can everyone hear me? Great. I'm a little new to this, so bear with me. And what I'd love is for the whole screen to be taken up with my slides. So we'll see if I can make that happen.
I just made you co-host, Lynn, so you should be able to do that right now.
Okay. Are you looking at my, oh, let's see. Are you looking at my, just my, is all you can see my screen? Or
Go
can you
ahead
see
and
my,
hit the
can you see
share
my notes?
button. Can you see the share, the green arrow at the bottom that says share?
Yeah, hang on.
Go ahead and click that.
Mhm. Let's see, I want this one. How we doing?
We got it. Looks great.
Great. Okay, well, thanks to everyone who's here listening today, and all the speakers have been fabulous. I'm glad I've been able to listen to everyone today as well. So let's see, I think I'll be able to switch back and forth through my own slides. I'm not sure. I might have to have you flip through them for me, Christine, but I'm not seeing that. Anyway,
I can definitely do that. I can pull them up for you right now.
okay, awesome. Yeah,
Not a
I see,
problem.
but I'd like to figure out how, but
No worries. I'll bring it up right now for you so that way you don't have to worry. You can just do your presentation.
okay. Well, there's only 9 slides, so I might be able to catch us up on a little timing here too. So, but I will say, you know, I end today with a case, thank you, with a case study. And it actually is interesting that it's a patient with a history of traumatic brain injury. So that sort of ties in a little bit with Dr. Drapcho's piece. So thanks everyone for being here. All righty. Let me see. Yeah. Great. So what is Patient Navigator? I'm not sure if that's supposed to be a little animation that will drop in. I'm not sure if you are able to click on it, Christine. There we go. I can be fancy too. There we go. So yeah, the Patient Navigator is a healthcare professional basically whose job is to provide guidance and support for patients and their families as they interface with the nuances and complexities of the health system. And as Dr. Drapcho also said, you know, it does take a village to care for epilepsy patients. So if you think of it that way, I like to think of the patient navigator role as sort of maybe the town crier, or someone that is able to connect all the pieces of the puzzle. It's a big task to have someone go from home and then into the hospital and then make them feel comfortable going back home as well. The providers do a fabulous job of, I think, explaining the whole process to patients as well while they're here. My job is a little bit more on the front end and explaining the epilepsy monitoring unit admission to the patient over the phone, usually before they come in. And all the pieces of that puzzle and asking them lots of questions to see if I can help streamline their admission and make it overall more efficient for the whole team. I am going to read a little bit off notes, and not always such a great extemporaneous speaker. So if you see me looking down, that's why. I just don't want to forget anything that I've written down. I did have an example of sort of connecting those dots before and ahead of time. One example of that is like learning from a parent that maybe a prior EEG placement on a 6-year-old with autism did not go very well. So knowing that in advance of that family and their child coming into the hospital, it puts the parent at a little bit more ease to know that we're even asking that question, because it shows that we care about the fact that their child may not have had a great experience in the previous 2 times that they've had an EEG placed, whether it be in the office setting or ambulatory. So instead of waiting till that family is here in the hospital and then dealing with the repercussions of that, I try to get ahead of that. We try to let the EEG techs know in advance that the child had had a previous difficulty with that, so that they can the EEG techs can maybe allow a little more time in their schedule to stay with that patient while they're applying the leads. I also would try to connect in advance and give a heads up to our child life services specialists. They do a great job of providing pleasant and engaging distractions for kids while they're here. Ideally, they can coordinate as well with the EEG techs and be there during the actual placement. So again, trying to think ahead about all the little pieces that would make someone's experience, especially someone's kid's experience, go a lot smoother is part of my job. Just a note too on autism as a comorbidity. It's a very common comorbidity that we see. And for those kids in particular, they can be very intimidated by their space being invaded. So putting EEG leads on someone's head with autism can be very intimidating. So we try our best to mitigate that as much as possible. And the staff is so amazing with that. Another thing that patient navigator role hopes to help with is identifying healthcare and community resources, such as the Epilepsy Foundation, and trying to connect patients with those organizations, either during their admission or afterwards. Christine is great if I shoot her a message and say, hey, I've got a patient that's really interested in talking to you or learning more. She's wonderful at zooming in, and I don't know what happens on that side, but she makes some additional magic happen for our patients, so it's wonderful. Go to the next slide. Thanks. So just a little history of the role. I won't read through everything here, but the patient navigator role originated back in 1989 and was first put into use in 1990. So it's been around about 30 years. Started off with cancer patients, actually. If anyone here has ever known anyone with a cancer diagnosis receiving treatment through the medical system, you might know that it can be a very involved course with multiple providers, multiple steps of the process, and a patient navigator can really help talk someone through what that's going to look like in advance. I'm fortunate enough to work with a couple fabulous teammates here who do work with primary brain tumor patients here at Maine Med. So I learn a lot from them every day. Let's see. Yeah, we can head over to the next slide. Yeah, so this slide, I think, points to also what Dr. Trapcho was saying, that, there are many pieces of the puzzle. It does take a village. And also, these patients are so unique, each unto themselves, that it really takes, talking with someone through lots of different questions. Well, we can head over to the next slide. I'll just talk over this a little bit. So epilepsy, as we have discussed, is really multifaceted as a chronic disease, multifaceted for many reasons. It has a range of severities. As we mentioned previously, stop, I'm getting a message here. Sorry about that. Yeah, so patients can be basically manage on 1, 2, 3, 4, sometimes 5 medications. Sometimes still get breakthrough seizures, as has been previously discussed. There are different types of seizures that patients have, focal, generalized, and then I think it's about 3 to 12% of seizures are of unknown origin. So super important for them to come into the hospital for an epilepsy monitoring unit stay. If there are any questions about that. And even sometimes after an EMU visit, it still isn't super clear, but it's always gives a clearer indication of what the source is. And as we also discussed, there are functional seizures, or PNES, as were previously discussed as well. So, in talking to these patients coming into the hospital, having an idea of the types of seizure they're having, what their symptoms are like, and being able to convey that to the staff is something that's helpful as well. So the staff knows what they're going to be looking for. And I'll do that in various ways. Mostly if a patient's coming into the hospital, I try to message the entire team before they come in and give a write-up about the patient and say, this is what this patient has been dealing with. This is what we should be looking at. So at that point, I've done a pretty thorough chart review and have a decent idea of what would be important to convey to the care team before the patient comes in. And we talked about there being different causes of epilepsy as well. So all this is just to say, speaking with patients requires knowing enough about epilepsy that you can speak to their individual concerns or issues that they might raise. As the slide is about, the EMU admission is really about bringing a patient in to the hospital to capture their seizures and characterize them so that the providers can then know how to best treat them. So really conveying as much information about what the admission is going to look like is super important for the patient to feel confident enough to come in. It's not every day that, or I can imagine it not being something everyone would look forward to have to go into the hospital for anywhere from 2 to 5 days and have complete strangers try to get you to have a seizure in front of them. So it's a very daunting experience for a lot of folks. So I really do my best to, all in about a, half-hour conversation to give them all the information I can about the epilepsy stay, but also hear their concerns and speak to them and try to limit or relax them, I guess, into the idea of the admission, so they're not so scared and nervous that that they don't want to come at all, because it's super important for them to come. So some of my most gratifying phone calls are really when I'm listening to a patient and really fielding their concerns, and I think it's super helpful for those folks as they come in. I think we can change the slide. So in a nutshell, this is Peter Drucker, who is a famous, I guess, businessman. Efficiency is doing better what is already being done. So a piece of my job is, as I think of it, is to really enable everyone who has to touch a patient coming into an epilepsy monitoring unit stay, including the pharmacists, nursing staff, EEG techs, the providers, giving them the residents, getting them as much information about this patient in advance so that their work can be more efficient. I think oftentimes people confuse efficiency with fast, and efficiency is really not fast care, but it's well anticipated and thoughtful care. And so that's really my goal in doing this work for patients. Let's see. Yeah, my notes just suggest that, many multiple seemingly small things enhance the patient experience and the care team members' experience of efficient care. Again, letting the staff know when the patient has actually arrived at the hospital is something I try to do, because the EEG techs and the nurses can be busy in their roles and, not know that it's time to free time up for this patient that's coming in. So they're not sitting around waiting too long to get their EEG leads applied. So I do try to keep a tabs on even patient arrival. If someone's coming from 5 hours away and they're going to be late getting to the hospital and they give me a heads up, I can let the care team know. So I'm happy to, yeah, exactly. Exactly, Joey. It's such a crucial role. Let's see. I try to coordinate with the pharmacy team before the patient comes to the hospital. Try to ensure up-to-date medications and doses. Let's see. There's sometimes when we don't actually carry a certain medication that the patient is on here at the hospital. So, it wouldn't be good to have someone come into the hospital to receive care and then tell them, oops, I'm sorry, we don't have that medication. So it's another piece that I try to connect with the pharmacy techs about. The pharmacy tech will call the patient before their admission. And that's a piece that makes so much difference in terms of smooth, efficient care. And it also makes the patient feel like they're being cared for. I mean, all these little steps, are so important for. I think it's easy to lose sight of the fact that all these little things help people feel cared for. So that's really what my goal is. Another part of my job with bringing patients into the EMU is, at least what we do here at Maine Med, is we will sit and have a huddle together. So that's me, the provider, the resident, if they're able, the pharmacy tech, the nurse, CNA, the charge nurse on the floor, and we all come together prior to that patient's admission and talk about that patient that's coming in, or all of them that are coming in, to see if anyone has a perspective that is different from what I've presented. I do my best to present as much as I can that's appropriate, but sometimes a med will get missed, or sometimes the nurse will say, how about we get a recliner in the chair so that, when the EEG tech is doing their interventions, the patient is more comfortable. So those sorts of things really make a difference in patient care. So that huddle is a great place for us to all get on board with the patient and help look ahead to see if there's anything concerning that we haven't addressed that might affect their stay here. Some patients have inadvertent behavior, as we've talked about, either immediately after or during their seizures. Wandering is one that we try to get ahead of. So asking patients about the nature of their seizures before they come in is so important, because if they say, or if a parent says, boy, my son, when he's having his seizures, he just wants to move. He just wants to move. And, it's important for us to keep our patients hooked up to the EEG monitor that they're on. So if they want to wander too much, such as out into the hallway, you can imagine where that would be a problem. So we'd like to get ahead of those things as well. Yeah, that would be a definite no-no. So I think we can move to the next slide, Christine. Oops, I'm not hearing you. Are you talking to me? Yeah.
Sorry about that. I thought it was unmuted. It said, are your services available to people coming into the emergency room with a seizure-related emergency? That was a question that was posted.
Oh, yeah, that's a great question. Unfortunately, no. We really are, for planned admissions, primarily. I would be open to receiving, a phone call, or if a patient ended up getting admitted and they wanted to just talk to me about some questions or concerns, I'd be happy to go up and chat with them. But in general, this is, again, a huge part of my job as pertains to the EMU, is about getting as much lined up ahead of time as possible, so the actual admission goes well. Ideally, yeah, that would be great if patients coming through the emergency room that do get admitted could be hooked up to our services. That would be great, and I would be always open to that. So great question. Let's see, where are we here? Yeah, I mean, I don't know. I didn't know how much I would have to talk about the nature of the epilepsy monitoring unit. I would imagine most folks here have an idea of what that is. Christine, are you able? I had a little video on that where it says absence seizure video. It's just a quick video of someone having an absence seizure.
Oh, yes. Love those live seizures. Yes. Happy
Let's
to
see if
share
it works.
Okay. I'm going to go ahead and share my sound. So that way everybody can hear what I hear. And what I can do is make sure.
If it doesn't work, that's okay.
Nope, I'm going to get it. Oh, you brought up one of my favorite videos.
I'm sure a lot of people probably have seen it. Yeah.
I use
great.
this in our trainings. We use these in our
Cool.
training. Okay, I'll go ahead and share it, and I'll start it, make it bigger. Can everybody see this and hear this? I hope.
This girl has absence seizures, and you will see her have one while she's talking.
Because he can be as heavy as ever.
And there's a real blankness, a vacant look in the eye, and then all of a sudden they're right back with you and able to engage.
Oh, pardon?
Sorry?
I thought you said something.
Absence seizures can be mistaken for daydreaming. One of the hallmarks of absence is that the seizures happen many times in a day. Sometimes they're so fleeting, they're easy to miss. This boy is having frequent but very brief episodes. You can see his eyes flutter up. He's out of touch.
What I'm photographing now? Lucky I like
Then he becomes fully aware again.
We're supposed to take a lung sample, so just...
Do you want me to play the next one too?
No, that's all set. Thank you.
All right, no worries. I'll go ahead and reshare what we need to see.
Thank you.
You're so
Glad you're
welcome.
here. And one of the things that I didn't touch on yet is that at least here at Maine Med, we make every attempt to have a patient's family or a friend come in and actually stay with them during their epilepsy monitoring unit stay. So you're really educating a couple people and not just one or another parent or that sort of thing. But there are times when there are patients who have literally no one that can come stay with them, no family or no friends. There are people that, for example, live in group homes. And my case study, we can go to the next slide, does pertain to a gentleman who does live in a group home. I'm going to kind of read this off my paper. So again, I'll be looking down, but so the area that's circled in blue there is what a traumatic brain injury looks like on a CT scan. This individual had an unfortunate event in his childhood, did have some damage to his brain. And he continues, he's now 59 years old, lives in a local group home. And we do have some people here at the hospital that sometimes are able to sit with our EMU patients. But unfortunately, there so many patients in the hospital needing sitters that sometimes we're unable to guarantee a sitter that can stay with someone for 5 days, days and nights. So that's a real big ask. So this was a gentleman for whom he lives in a group home. There was no one from his group home that could spend 5 days out of work to be with him. They just didn't have, it's not that they wouldn't do it, but they just didn't have the staff to allow someone to come in to assist him. They really wanted him to get some care. So I'm just going to read this down through. EJ is a 59-year-old male with cognitive challenges living in a group home. His CT scan looks similar to this one, with an unfortunate history of traumatic brain injury / trauma. He regularly experiences seizure-like events consisting of lightheadedness, unsteadiness, confusion, amnesia, and occasional incontinence. This is challenging for his group home. The ever-changing, rotating staff is not necessarily trained in seizure management. Staff turnover is high, yet EJ's safety is their primary concern. So generally, when he's experiencing these symptoms at his group home ends up calling emergency medicine, EMTs, who come to the group home, then take him to the emergency department. This was happening multiple times a month and sometimes as frequently as once a week. Often EJ is back to his old self by the time he can be seen in the emergency department. He's been on anti-seizure medication for a long time, but these events continued to occur for him. Once he was so confused, he tried to pull a refrigerator over. So this is a gentleman that needs to come into the EMU with maybe some behavioral concerns, safety concerns that we might want to be conscious of. He's very lovely, very pleasant, jokes around a lot, but becomes a little less predictable when he's in the middle of his symptoms, I guess I should say. His neurologist hoped that if his events could be shown to be non-epileptic, or the PNES, because that hadn't been proven yet, whether these were true seizures or whether they were PNES, then staff at his care home could safely support him through these symptoms rather than always having EMTs come and take him to the emergency department and get treated there and sent home. So they were hoping to mitigate this back and forth to the emergency room by getting a known diagnosis. So this is all to prepare you for kind of more steps that I took to sort of get this very particular patient with these very particular circumstances into our EMU to help with the diagnosis that could help prevent him from these constant trips to the emergency department. So bear with me, thank you. Due to his history of traumatic brain injury, his neurologist felt it would be safest for an actual person to stay in the room with him. But as we discussed, we didn't have the capacity for that. He is a big, tall guy. If he stands up and then gets dizzy, he could easily fall and hurt himself. This is not something that in general we like to have happen in the hospital. So I misspoke previously. His neurologist did want somebody to stay with him, but no one from his care home was able to do that. So, and he had no family or friends. And it looked like he would have to stay here for about 5 days. So to make this admission happen, we had to not only contact the hospital sitters and really say, look, this is a very special case. This is somebody that we need to have around the clock, personal, someone to be with him around the clock for up to 5 days. This is a special case. Is there any way that we can make this happen? So our navigator team met with nursing leadership to brainstorm how to help this patient. Luckily for him, due to an influx of summer help, we were told additional staff were available to sit with him 24 hours a day throughout his admission. So it was really, the timing was perfect, and we just got lucky. When I conveyed this to the group home, they were thrilled. We then scheduled a date, and I explained the ins and outs of the admission, requested a current medication list. They faxed it to me. I got it to the team on the floor. I then contacted the hospital's staffing team weeks ahead to make sure that 24/7 care would happen. I didn't want anyone to forget because if they forgot and they didn't have anyone to stay with them, we would have to cancel his admission because it just wasn't safe. I reminded them 4, 2, and 1 week out that we would need someone. The staffing team then communicated with the floor nurses from a patient safety perspective to let them know that he'd be monitored 24/7. I sent an email the week prior to admission informing all the teams about our plan of care. The day of admission, I notified the teams when he arrived at the hospital. The entire care team then met in our huddle to discuss his care and clarify any questions or concerns. I actually did go down and meet him at the door, and he had a lot of stuff with him that we piled onto a wheelchair and got it up to the floor for him. During his stay, EJ did ultimately experience his typical symptoms, and the sitter that we had worked so hard to stay with him actually did keep him from falling during one time when he had stood up and felt his typical feelings or symptom of dizziness. So it proved extremely worthwhile to have an actual attentive human in the room. We do have a video monitor that also watches the patients while they're in the room. But again, that can't intervene or have someone sit on the bed if they need to keep them from falling. So let's see. Because EJ's ability to retain information is extremely limited, and also just for continuity of care, I told the group home that I would call them on a daily basis during his admission to update them on his progress, because he really didn't have the capacity to call them and update them himself. And they were very appreciative of that. In planning for his discharge, I connected the case manager to the group home to schedule his ride home from the hospital. The care manager appreciated hearing about the patient prior to her calling the group home, just because he was a new patient to her. So I was able to fill her in before she called them cold. And that she just said that was very helpful for her to be more efficient in her part of her job. So there's, anyway, lots of pieces along the way. And hopefully this case exemplifies the multiple levels of communication facilitated by the patient navigator to make these admissions happen. And again, a one size does not fit all way. Helped a very anxious individual end up having a really nice stay here. He ended up saying multiple times, "I love it here." So that was very gratifying, and his stay really did help him get the treatment that he needed. And his emergency department admissions went way down as a result of his recent stay with us. Hopefully that gave a good impression of sort of all the steps along the way. And if there's any questions, I'm happy to take them at this point. Thanks for listening.
Lynn, would you
Oh,
like
thank
to
you,
stop?
Joey.
I was gonna say, do you want me to stop sharing?
Sure.
Okay.
Thanks everyone for listening today and for being here, and Christine for your ongoing assistance with our patients.
Oh no, it's a lovely partnership. I enjoy working with all of you, and you know my personal connection with epilepsy, so it's nice to be able to bring. It's where we started, and where Delia was welcome and loved very well. So we're very lucky to have all of you guys be a part of Maine Medical Center and helping our families feel comfortable and navigate such a bumpy road and journey with epilepsy. We know it can just be really rocky sometimes for those families. So Lynn, the work that you do with the families there at Maine Med is huge. And I agree with Joey 100% that the work you do sometimes it isn't always, a lot of families don't know that sometimes you're available. So thank you so much for taking the time today and for sharing with us the role of the patient navigator and the work that you do with the families to help connect and bridge that gap between home and the hospital, because it can be really scary for families, especially if they've never had a hospital stay before. So thank you so much for everything that you do.
Thank you.
Appreciate it. Awesome. Well, we are coming upon our last speaker. We're a little over, and that's okay. We're at 1:15. It was supposed to be discrimination in the workplace and the vocational rehabilitation program with the Department of Labor. So today we have Dawn, who is from the Division of Vocational Rehabilitation from Portland, Maine, which is also part of the Department of Labor. And she is here today to go ahead and speak about exactly what the Job Voc Rehab Program is. These are programs that I'm sure she'll share that can be found in each of the states that you live in. So they are federally stated programs. So you can find these several times. So Dawn, I'm going to go ahead and make you co-host. So that way you
Great.
can then share your slides and take over.
Thank you.
You're so welcome. And thank you so much for volunteering your time today to
Oh,
be
sure.
here with us and educate us about the amazing programs that the Department of Labor gives for individuals with disabilities. So thank you so much.
Sure. Thank you. Yes, Division of Vocational Rehabilitation is kind of one of the best kept secrets, I think. I am a casework supervisor from the Portland office of the state of Maine Division of Vocational Rehabilitation. And we have a number of different divisions that are part of that. So I'm going to share with you a little PowerPoint that talks a little bit about our different services. I'm going to do like a 10-foot, 1,000-foot level discussion, but certainly after I'll open it up if anybody has any specific questions. So without further ado, I will share my screen and hopefully we can get it to work properly. So do you see my PowerPoint right now? Correct? Do you see the PowerPoint? Yes? No? Maybe. Are you all set? Okay, great. Thank you. All right. So vocational rehabilitation and the pathway to meaningful employment. What we are charged with is assisting individuals with disabilities to secure and maintain competitive integrated employment. We, in the state of Maine, vocational rehabilitation is part of the Maine Department of Labor. As Christine mentioned, there are divisions of vocational rehabilitation in every state in our union. We are all given oversight from federal and state agencies. Our governing body is the Rehabilitation RSA, the Rehabilitation Services Agency. And different states have vocational rehabilitation under different umbrellas. Some have the Division of Vocational Rehabilitation as part of education. the Department of Ed. In our case, in Maine, we have the Department of Labor, but our services are all very similar. And in Maine, we are also part of the American Job Center Network. We all try to work together, and I'll talk a little more about that. Next slide. So part of in the division of Maine Department of Labor, the Bureau of Rehab Services is in charge of all of our different divisions. And there are 3 different divisions that are part of us. Actually 4. There is the Division of Vocational Rehabilitation, which is where I work, which is individuals with all disabilities. Then there is the Division for the Deaf, Hard of Hearing, and Late Deafened. And that obviously is for individuals who have hearing challenges. And then we have a division for the blind and visually impaired for individuals with visual challenges. And then we have our systems improvement and quality insurance. We are all part of the Maine workforce system, and most of our offices are co-located with not only career centers, but also Department of Health and Human Services. We try as much as possible to be kind of a one-stop for people to avoid people having to come to multiple places. So again, Voc Rehab is a state of Maine program. We receive federal and state funding. We assist individuals with disabilities to prepare for, find, keep, and advance in competitive integrated employment. We provide services to anyone who is a transition age student from the age of 14 up to 24, young adults, and also adults of any age. There is no quote unquote maximum age. We have a number of individuals we work with who are in their 70s and 80s. So it really doesn't matter what the person's age is. Eligibility for our services is pretty simple. You're eligible for services if you have a physical, intellectual, or mental impairment which results in a substantial impediment to employment. And you require VR services to help you prepare, secure, retain, or regain employment. We are a voluntary program. People are not forced to come here, and we are very much client-centered and client-driven. How do you reach our services? We have an online application. I don't know what's easiest, Christine, whether I should just share the PowerPoint with you, or we could put the links in the chat, or both.
We can definitely do both, Dawn. I don't mind doing either one.
Okay, so we can do both. There is also an opportunity online to download the application in Word format if online doesn't work for the individual, if they need assistance filling out the application. Also, anybody is always welcome to walk into any career center in the state of Maine and just ask somebody to help them fill out a VR application. We try, there's no one set way to apply for our services. So just have somebody either get to an office or call an office, and we'll find a way to help them apply for services. And again, the Portland office where I work, Kim Desso is our regional manager, and the 2 casework supervisors are myself and Sean Nixon. And again, you can always just call our office too, and anytime, or any office in the state of Maine, and just ask to speak with the counselor of the day. And they'll get you the links, they'll get you an application, and do what they can to assist you. So once somebody applies for our services, an intake interview is scheduled to gather the medical information and other records. If a person receives SSI or SSDI that is based upon their own disability, not on their parents' disability, or retirement benefits or any of that. If it's based on their own disability, they are what's called presumed eligible for our services, which means we already figure out that they're eligible. And the reason for that is, as you all know, the standard for SSDI is a pretty high standard. And so we recognize that if somebody meets the standard to be disabled as far as Social Security is concerned, they're disabled as far as we're concerned. Eligibility must be completed within 60 days as per our federal regulations. If that's not possible to happen, the client may be asked for permission to extend their application, and they sign a form giving permission. And unfortunately, these days that happens a bit because, as you can imagine, many hospitals and such forth, it's taking about 6 to 8 weeks to get records. So just to let people know, they may be asked to sign an extension. So right now there is a wait list for our services, but only for individuals who are not most significantly disabled. So VR programs are required to serve individuals who have the most significant disabilities first. And when individuals are found eligible, they're placed into priority categories based upon their functional losses, the number of functional losses and the different categories of the functional losses that they have, the different dimensions. Individuals with the fewest barriers are categories 3 and 4. They're the individuals who are placed on a wait list. And those are the individuals. And again, this is only for DVR, not for DVBI. But for DVR, this is the what is happening right now. And DVR, Division for Deaf and Hard of Hearing, is also part of DVR. So individuals who are in those category 3 and 4 are placed on a wait list at this time. Significant individuals with more significant needs are able to be served now, category 1 and 2. And generally, so what does that mean? Generally, many of the clients that we work with that, live in group homes, have waiver services, have case management, 9 out of 10 of those individuals are going to be probably a category 1, possibly a category 2. So the individuals who are being placed on the wait list are generally people who are pretty darn independent and really don't need much service. So, and Christine, I don't know if you noticed, but there is somebody in the waiting room. So I just wanted to let you know that. I don't know. I'm getting notice of it because I'm person here. So, all right. So then, oops, sorry, we have my thing got a little bit forward. So one of the guidelines that guides us is the Workforce Innovation and Opportunity Act. And that when that was passed, that directed us to increase our collaboration with our partners. And partners are for this context considered things such as schools, case management providers, employment providers, hospitals. So that's part of why we do increased outreach, because there's a recognition that we need to look at clients from a whole person, from the whole perspective. And so we try to invite all individuals of the team to provide their input so that we can promote this competitive integrated employment. We are also required as part of the WIOA Act to set aside 15% of our funds to provide what you might have heard termed as pre-ET services. Those are pre-employment transition services. So those are services for high school students. So we are federally mandated to spend at least 15% of our funds on high school students. And this does not replace the requirements of the schools that come through Maine Department of Education and under the IDEA Act. So there's kind of multiple things that guide us as far as school go. So what are pre-ET services? So pre-ET services are services that we generally provide to students. So some of these services are listed here, and I'll just say a few quick words about each one. Job exploration counseling. That's really assisting a student to just try to figure out what the heck is out there. What is available to them and what are the different jobs that are in the community. Work-based learning experiences. We try to ensure that every student working with VR has at least one work-based learning experience before they graduate from high school. Work-based learning experiences are short-term job trials. They are paid, and generally there is some level of coaching at some point through the experience. Doesn't necessarily mean there's a coach there all the time, but there is a coach there at least some portion of the day. Counseling and opportunities for post-secondary training and education. We assist students to navigate the kind of world of financial aid and getting ready for college and tutoring and getting connected with disability services. We assist students to kind of navigate all of those things and help them figure out what are the different steps and the next things that they need to do. Workplace readiness training to develop social skills and independent living. We have a number of different options and resources in which we assist students with that. We have something called, what used to be called virtual job shadow, which is virtual courses and trainings and assistance to teach students skills. In every, or most every high school in the state of Maine, we have certain VR counselors who are assigned to that school. Those counselors work closely with the teachers to ensure that VR is aware of students in that school and works with the teacher to figure out what resources are best for that student. Sometimes it's in workplace learning experience in the community. Sometimes it's job tours. Sometimes it's community tours. Sometimes it's virtual training or, through our virtual job shadow program. We also have different career exploration workshops that we can set students up with either in school or after school. And then our regional provider also provides something called boot camp, which is where they work very closely with students throughout the year, and they do regular classes in school that talks all about workplace readiness, and it all ends up with generally workplace learning experiences. So boot camp is a really all-encompassing thing that kind of lasts throughout the whole semester. And then we also assist students with instruction and self-advocacy. So that's a really important part. So when somebody comes to VR and they're deemed eligible, they're assigned a counselor essentially based upon their disability. If somebody has any type of disability other than blindness or difficulty with hearing, they're assigned a general vocational rehabilitation counselor, VRC 2. The VRC 2s are the counselors who are responsible for the caseloads, and they essentially manage the cases. We also have VRC 1s who assist, but the VRC 2s are the individuals who are qualified to make decisions in the case. For individuals who have visual challenges, they're assigned a blindness rehabilitation specialist. And they're essentially similar to VRCs, but as you can imagine, they receive significantly more training on assisting individuals with visual challenges. And if somebody has hearing challenges, they're referred to a rehab counselor for the deaf. And again, very similar to a VRC, but rehab counselors for the deaf get significantly a lot of additional training for supporting individuals who are deaf. We also have a number of rehab counselors for the deaf who are deaf themselves, and so they speak American Sign Language. So that's another option as well. And again, whenever you have any questions about just VR in general, you can call any career center, Department of Labor, Bureau of Rehab, VR, and just ask to speak with a VR counselor of the day, and they'll get you to where you need to go. So once somebody is deemed eligible for our services, they would work with their VR staff member to create their plan for employment. And essentially, the plan for employment is the goal that they're looking to pursue and look for in the community. And it's based upon a number of different parameters: their interests, skills, and abilities, the labor market conditions, barriers that the individual might have, accommodations they might need. And throughout the whole process of working with the client, the VRC, and just to make things easier, I'll just call VRC, but when I say VRC, I mean VRC, rehab counselor for the deaf, or counselor for visual supports. So the VRC will look at the labor market conditions, the barriers and the accommodations, and the VRC will complete what's called our comprehensive assessment of rehabilitation need. And what that is that's a living, working document that just puts all the information in one place and helps us synthesize basically all there is to that client and helps us figure out what makes sense for next steps. So the individual plan for employment, it outlines these steps to achieve the work goal. It includes specific services, training, and the supplies needed to achieve the goal. It's generally reviewed at least annually, but it's changed and updated as needed. Career pathways are emphasized, and generally cases are closed then after the client has been successfully employed for 90 days. VR is generally not a long-term service. We are meant to be I don't want to say short-term service, but we are a purpose-driven service. If somebody comes, we assist to meet their needs, the case is closed. So the intent is to keep the case moving forward. So career pathways, I mentioned, what does that mean? Well, generally, when somebody comes in the door, as you can imagine, people are kind of all over the map as far as whether they understand what it is they want to do or how far along in their discovery they are. So when an individual first comes in and they start speaking with their counselor about what it is they're interested in, the counselor has a number of resources, not just in schools, but also for adult counselors. We have a number of different, websites and resources and exploration activities. And we have an entire career exploration workshop. And the whole purpose is to assist the client to really kind of hone down their interest, skill, and their challenges. And from there, that's how we figure out whether or not a job goal is viable. So what defines a viable job goal? A viable job goal is one that interests the client, that they feel they can do, and that whatever challenges they have can be accommodated for in that position. That's a viable goal. So once the counselor and the client agree upon the viable goal, they then set the career pathway. And the career pathway is, what do we need to do to get there? And as you can imagine, that is different for every single client. But that's the role of the VRC, is to help the client figure that out. Next slide. Okay, so excuse me one second, I'm very dry. Actually, are there any questions for this second while we're here? No? Okay, so I'll keep going then. What are the VR services that we do provide? Counseling and guidance, which is the assistance from your VR counselor. Career exploration, we have work readiness, workshops. We have work-based learning, education and training. We can do job development and placement. And job development is things such as carving jobs or helping, create positions or assist clients to share positions. That's all part of job development. Coaching, assistive technology. We can do support services such as tools or uniform or other equipment. We can assist people with self-employment. We assist with orientation and mobility, vision rehabilitation therapy, progressive employment, pre-employment transition services for students. So progressive employment, if you're not familiar with what that is basically it's a very special trademark model to assist individuals who have little to no work experience or who have very significant challenges. And the point of progressive employment is all about exploration of work versus placement. So that's another option that we have available. So for all VR services, they can only be funded if they're authorized in advance by a VR counselor. The Rehab Services Administration, our oversight agency, requires documented evidence that every expenditure has been prior approved by the VRC. So generally, we are not allowed to reimburse things. So one of the most important things is if you have a patient or a client who needs something and they need help to get it, don't have them go get it assuming VR can reimburse, because unfortunately that is one of the limitations. Generally, we're not able to reimburse things, but we can purchase things outright ourselves. So we do discuss comparable benefits. As we are stewards of state and federal funds, we are federally mandated to purchase things in a reasonable and necessary, most cost-efficient means. So we need to look at what are the cheapest versions, and it doesn't always mean we purchase the cheapest versions because we weigh all, parts of it. It's not, sometimes the cheapest is not always the best. So we look at what is the most cost-efficient means to achieve the client's goals. So we will look at if there is a way to get something without a cost and it will meet their needs. That might be something VR cannot fund then, because it is expected that will utilize the most cost-efficient means. Additionally, clients may be asked to share in the cost of services. Now, we would never ask a client to purchase something, and put them in a place where they couldn't afford their normal living expenses. So and we recognize that a lot of times there are situations where clients do not have money to contribute, and that's okay. But we have that conversation. And as I mentioned, services are required to be provided as cost efficiently as possible. So expectations for a client. As I mentioned, we are a voluntary service. So there have been situations where people's guardians or case managers or physicians have told the client that they need to apply for VR. Or general assistants, that's another one. Sometimes general assistants will tell people they have to apply. Now, we accept all VR applications, but we do not, quote unquote, force a client to participate in VR services. So if a client chooses not to participate, their case might possibly be closed because they're not actively participating. So it is expected, did not mean to do that. It is expected that the client will be an active participant in their VR process, that they will take ownership of their decisions through informed choice and follow through on plans, that they will share their strengths and barriers with their VR counselor, that they will identify supports that will help overcome barriers, that they'll be open to different jobs and trials, and that they'll advocate for themselves. Now, that being said, we also understand we work with individuals of all cognitive, communicative abilities. So it runs the spectrum. Some clients may be able to do all of this completely independently. Other clients may need hand-over-hand assistance to meet these goals, and that's okay. It's all about what is required for the client to be successful. So our responsibilities is to encourage and develop an ongoing relationship, to encourage exploration of vocational options, to provide guidance and counseling, to encourage clients to take risk, to assist with understanding how employment impacts their benefits, and to provide resource information, including CAP services. CAP is the Client Assistance Program. Right now, DRM of Maine are our client assistance providers. So anytime a client disagrees with something that happens with their VR case, or they're having challenges with their VR case, we encourage them to connect with DRM, and they help serve as a mediator and a client advocate. Practices to support success. So as we're working with counselors, you're going to see, as with any other provider, we're going to ask for signed releases. We're going to try to have effective communication. It is okay for a case manager or a doctor or a family member to advocate for the client, but this does not replace direct communication with the client. The VRC is still going to ask for the client to participate in whatever way they are capable of doing. Again, we have a very client-centered philosophy, as I've mentioned, and planning employment starts, the process always starts early, and it continues throughout the whole time. We are always talking employment supports. In each region, we have a community rehabilitation provider that assists us to provide services to clients. In each region of Maine, there are different providers, and this is just a discussion right now of who are our providers at this moment. These contracts generally change every 2 years. Right now, though, Goodwill is our provider for Region 1, 2, and 3, and Living Innovations is our provider for 4 and 5. But again, your VR counselor can connect you with these providers. It's not something you need to know. We also have in each VR office a liaison that works with OADS, the Office of Adults with Disability Services. And we work very closely with OADS to assist individuals with intellectual disabilities. And because that's such a large portion of the population and they have special individual considerations, we have a liaison in every office in Maine who is the DVR and OADS liaison, and they work together closely with OADS, and that rehab counselor is responsible to support all the individuals with ID in that region. So we work very, very closely with OADS. And so I'm not going to go over, because we're running for time, I'm not going to go over every little part of this, but essentially when we're talking VR, what does success look like? Well, success doesn't always mean just finding a job. You know, in this case, she did. You know, this is a woman who, she had some anxiety, and she used progressive employment, as I mentioned, to help her figure out what her employment interests are. And then they helped her do a work experience at a pharmacy chain, and then she ended up being hired. So that's an example of how you can go from somebody who's really, really kind of trepidatious and unsure about work, and we can help take them slowly through the process at their speed to help them feel comfortable with getting back into the workforce. Another example of success We had PJ who experienced a setback in his personal life, concerned that the job with the food company might be in jeopardy. VR came in and we brought a job coach in and worked with the employer and developed natural supports, which is people in the agency to help PJ. And that allowed him to remain a valued employee and to be successful. So, of course, both he and the employer are happy. A third one is Johnny, who's been a longtime client, who is also deaf, experienced barriers. He had an assessment. He worked with a community rehab provider that found a job at a building store. After reaching stability, he received long-term job coaching. And now he's working and everybody enjoys working with him. And he has a really great sense of humor now and says he loves everyone at his work. And he's very proud of himself and his job. And that's VR in particular. Now, there was, Christine did ask for me to talk a little bit about discrimination. And I explained, unfortunately, I am not, a lawyer or versed in discrimination law. What I can say about accommodations and assistance for individuals with challenges. A few things to remember when you're thinking about accommodations with a client. Number one, the bottom line is the individual needs to be able to complete all essential functions of the job. Now, they can require an accommodation to complete those essential functions, but you cannot ask for an accommodation that says, I can't do this function of a job. That's not an accommodation that's going to be accepted. The other thing is, when you're requesting accommodations, they have to be reasonable. So the accommodation needs to be something that is not going to cause undue hardship on the employer or the other individuals who work in the facility, because the employer does have the right to say no to an accommodation that is not reasonable or will cause undue hardship to other individuals. So that's another thing to think about. A third thing to think about when you're thinking about accommodations is, do not expect an employer to be able to tell you what accommodations will work for the client. That's really something the client needs to figure out. And if the client can't figure that out on their own, then that's where VR comes in. We can assist somebody. We can fund a workplace AT assessment. We can do learning disability assessments. We can do overall AT assessments. We can assist with those challenges. We also can connect people with Maine Site and various lending libraries where they can borrow AT to try it out. What I have found that actually kind of surprised me, but I've kind of come to grips with it now. When it comes to AT, sometimes it's just trial and error. You just got to try it and see if it works. And so that's why when we talk about AT, it's a good idea to get connected with a lending library. So, and then the final thing about AT is, if there ever is a situation where you wonder if somebody's been kind of discriminated against, I would encourage you, assist the client to reach out to either Pine Tree Legal, perhaps DRM, Department of Labor. We also have an ADA accommodation specialist. Her name is Rayleigh Guthrie, Guthrie. She can also help you kind of navigate some of that. She can advocate for the client or meet with the employer or coordinate with the VRC, whatever is needed. And I noticed a hand up. Question?
I was going to ask you, how have you seen situations where someone's in a job or or has employment, and then has wanted to do something like this and get help with seeking accommodations, and then have it kind of like negatively impact that person. Like,
Yeah.
and
Yeah,
yeah,
unfortunately, it has happened and it does happen. And that's why I recommend if you're thinking, your client is thinking that they need accommodations, do your homework in advance. Because sometimes it's about how it's presented to the employer. So if you present it to the employer as, I can't do the job and I'm not really sure what will help me, many employers are going to go running for the hills. But if you present it as, I'm struggling with this task, and this is what I need to help me reach this task, then you can spin it almost to like a benefit to the employer, because you can demonstrate how, if you allow me to have this accommodation, I can be a better employee for you. So it's do your homework ahead of time. And if you're not sure, reach out to Rayleigh, or if your client has a VR counselor, ask for help for that. My impression with employers in the community, I mean, let's face it, people are generally good. They want to help people. They want people to be successful. But I think sometimes when you start talking about accommodations, some employers go, uh-oh, this is now legal stuff, and I don't want to get in trouble. I don't want to touch that with a 10-foot pole. And I think that's where you sometimes see the resistance. And it's not because they don't care, it's that they don't want to get in trouble. They don't want to go there, you know? And so if you do your homework ahead of time and you present it in a way that, hey, employer, I've got something really good for you. This is going to help me help you. And this is going to help me be a better employee. I have found people are much more open and accepting. So, any other questions, concerns, questions about VR? And, you know, one of the things I can say, there is a lot of misinformation about VR out there. I mean, I've heard all kinds of things, from VR buys people cars to VR pays for, you know. What I can say is, if you hear something strange like that, chances are there might be a small grain of truth, but don't necessarily take it at the word for it. But generally, though, I think one of the really good things, and the reason why I say VR is the best kept secret, which we don't like, it seems people don't know who VR is. But I think one of the things to remember is there are so many things that we can offer. Pretty much anything a client needs to get to work, we can do it. I mean, I'm not even going to begin to detail some of the things I've funded that people are going to be like, are you kidding me? But if it's justified and it's what the client needs, you know, and our services, we are not limited by a certain number of dollars, or, you know, each client only gets this, and this. Absolutely not. As a supervisor, I train VR counselors that they should provide every possible thing they can to a client within our policies and procedures. So we don't come from a place of restriction. We come from a place of adding, what can we provide, and what services do we have? Christine.
I have a quick question for you, Dawn. So my daughter receives Katie Beckett for her medical. And we applied for her for voc rehab services in Maine. And she is accepted and everything else. She has an IEP, so it's going to be part of her transition program and stuff. But they talked about her doing job shadows and her getting paid for those job shadows. Does that impact her Katie Beckett, like the Maine care and all of that stuff?
Great question. And actually, just one clarification of what you're saying, because people I think are mixing up terms a little bit. Job shadows are generally where somebody just goes and watches a position. Those are not paid.
Oh, sorry,
Work experiences are paid. And I'm not criticizing you. I just want to make sure you understand there's a very big difference between the two. But you are absolutely correct. And we get that question all the time. Anytime somebody is being paid as part of training to prepare them for work, it does not or should not count against any of their benefits.
Okay.
Even the Social Security or SSI, because if they're doing a work experience, a true work experience, the VR counselor can write a letter to Social Security explaining to them that this is considered training, and then Social Security doesn't even count it towards SSI. So if you have a work experience, encourage parents to talk to the VRC about giving them a letter to demonstrate that it's not supposed to be counted. None of that income is supposed to be counted.
Thank you. That's been a question in my head since you got into the program. So thank you so much. I appreciate it.
You're welcome. Anybody else? Thank you, Joey. VR is a great program, and I've been working for the state for 22 years, and I didn't know about VR when I came to the state either. I started at Odes, I worked there for 10 years, and then I've been with VR for the last 12. And it's still amazes me how every day people are like, what is VR? I've never heard of it. And I do these trainings all the time because we just want to get the word out there. We want people to come.
And we're so glad that you do, Dawn, because your program is so, I just put in the chat too earlier that it's such an underutilized resource.
It is. It is very underutilized. You're right.
Helpful. Yeah.
I mean, we have some schools where, we're in the school and they've only referred 2 and 3 clients. And it's like, really? I mean, you have hundreds of students. We could provide so much more.
And the parents can self-refer too. So
absolutely.
I self-referred my daughter because she hadn't been referred yet. And how I learned about it was through these conferences with you guys through my work. And I self-referred her. So yes, parents, if your child is 14 and above, the program starts at the age of 14, right, Dawn?
Yes.
Okay.
Yes. Generally the age of 14. Yes.
Perfect. You can self-refer, fill out the application, and do it all together online. And it's just a wonderful program. I can't say enough about the work you guys do, Dawn. It's wonderful to have you in our states. And again, like I said before, Voc Rehab is in every state. So if you're listening from New Hampshire, you can reach out to the New Hampshire Voc Rehab, and the program is the same. So it's all relatively the same in each state. Providing services. Yep.
Yeah, we all have the same rules and guidelines. We interpret the guidelines slightly differently, and the procedures might be a little different, but generally we all have the same rules. We're all bound by the same expectations. So, and we do work very closely with New Hampshire VR. We share clients all the time. So, yeah.
Well, Dawn, thank you so much for spending your beautiful Saturday with us today.
Thank you.
Educating
it was
us
nice.
Again.
It was nice spending with you all, and feel free to reach out to me anytime. I will email you, Christine, the PowerPoint, and that will have all of my contact information. Just anytime you have a question, just email's the quickest way to reach me. Just zip me an email and I'll find out what it is you need. So,
thank you so much, Dawn. Thank you.
Thank you very much. You all have a great weekend.
You too. Thank
Bye.
you.
Bye.
I am happy to share Dawn's information at the end. I will send a recap email of all of the information that we shared today as well. Dawn, are you okay if I share your email?
Absolutely.
Okay,
yeah,
perfect. I will
absolutely.
do that.
Okay.
And I just want to kind of end. So we have 2 things we're going to end with today. The first one is I want to allow one of our sponsors to, both our sponsors to be able to say a quick word. We have Hannah Scott from Neurelis. And we have John Sullivan from SK Life Science. So I'm going to have Hannah go ahead and start, and then I'll zip right to John after.
Trying to unmute here. Thank you, Christine,
No worries.
for everything that you do to help coordinate the patients with the information and really bring the community together for all the resources that are available, and also with the providers at Maine Med. So I'm Hannah Scott. I'm the territory manager for Neurelis. We have Valtoco, which is diazepam nasal spray. It is utilized for immediate use seizure medication for patients 6 years and older, those experiencing seizure clusters or breakthrough seizures. So really, as a resource to providers, I can provide copay cards, any insurance coverage questions, demo sprayers, anything like that. And for to help support patients and their care partners, we have a website. It's myneurelis.com. And there's really a lot of personalized support there. Education, nurse educators. You can find out if your insurance is covered, and Maine is widely covered. Medicaid is preferred, and you can receive up to 5 boxes, which is 10 doses. And we have financial assistants who qualify as well. So a lot of resources here. And My Neurelis is for care partners and patients, and my information for any of the providers at Maine Med. I'm happy to answer any questions. Thank you.
Thank you so much, Hannah, for being here today. I also want to introduce John Sullivan from SK Life Science. John, thank you for joining us.
Hi, hello everyone. I'm John Sullivan. I'm the neuroscience account manager for SK Life Science. I want to thank you for the opportunity to be a sponsor today and participate in today's conference. And the presentations were very informative, and I really enjoyed being a part of this. I just want to get some of the basics for those that might not know. So I represent Xcopri, which is cenobamate tablets. It was mentioned earlier in Dr. Dropchow's presentation. It's indicated for monotherapy and adjunctive therapy for the treatment of partial onset seizures, so focal seizures in adult patients 18 and older. For myself, I cover Maine, New Hampshire, north of Boston for my territory. So my major epilepsy accounts, I have Mass General, I have Maine Medical, and I have Dartmouth. So I work along with all those epilepsy centers. I'm available to address any issues or concerns with Xcopri treatment with your patients. Along with my colleagues at SK Life Science, I can provide educational resources, provide access to our medical team, and help with any market access issues for your patients on Xcopri. So, I just want you to keep in mind, 50% of seizure reduction should not be your goal. Aim for 0 seizures, and I hope you can do that with Xcopri. So, you can connect with me, or even I know Christine has my contact information. So if anybody needs my help or assistance, I'm more than happy to help out. And again, thanks so much for letting me be a part of this.
Thank you so much, John. I so appreciate that. So one last thing before we leave, I just want to, I like to always do this in my conferences, is if you haven't had a chance yet to really peruse our website, it's epilepsynewengland.org. I really urge you to do that. We have under programs is where you're going to see all of the different groups that we have and when we do. So please do. And again, these are all free, so you won't need to pay for any of these. We have camps as well for adults and for children. So please, we have an adult retreat coming up between the 27th and the 29th in Vermont. So again, and they happen throughout New England, which is wonderful. We also have our events page. If you go to that, that's going to be where you're going to find all of these wonderful educational opportunities. Here's the information about our virtual Maine Epilepsy Conference that was today. Here's that information for that meetup tomorrow at Fort Williams Park in Cape Elizabeth. So I hope to see you if you can be there. Here's the Wednesday webinar series. So if you go through, it'll list, we have free seizure first aid training. So if you want to take part of that, you can. But again, take a minute to go through and really peruse our website, because there's some really great pieces there. So if you have not done that yet, I really urge you to do that. But I want to thank everybody for being here today. We had a host of amazing speakers, tons of information. This is recorded, so I will be sending out the recorded link. You will get an email from me by probably the end of tomorrow. But I want to thank all of us for being here today and enjoy the rest of your weekend. I also want to thank again to our speakers from Maine Med. Thank you again for being here and joining us today. So thank you so much, everybody, and have a great day.